Assalamu alaikum and good afternoon, everyone. I'm Farah Asif, and I'm delighted to be joined by our attendees, our speakers, as well as panelists. This is an honor to welcome you to 20th Shaukat Khanum Cancer Symposium, which is hosted by Shaukat Khanum Memorial Cancer Hospital and Research Center, Lahore, Pakistan. Shaukat Khanum Hospital, it has a long commitment to ethical conduct of research, and it is reflected by existence of research guidelines as well as institutional review board since 2005. And this is a time when having these developments was not very common in Pakistan. Shaukat Khanum Hospital has supported different initiatives to support ethical conduct of research that includes development of human resources, infrastructure, as well as other similar initiatives. During COVID-19, we have upheld our commitment to ethical conduct of research. We have learned, we have evolved, and we have done necessary adaptations. As we continue to live in COVID-19 emergency, we are facing complex challenges at individual level, at regional level, as well as at global level. The situation was not friendly to do research. However, it was important to do research to understand the characteristics of this novel disease, as well as to understand that what treatments might be effective for the treatment of COVID-19 infection. It was important, it was mandatory to find out what preventive strategies would be of help, as well as to development of vaccines. The situation presented a broad spectrum of challenges, which evolved over time. With no knowledge of what treatments would be effective in this infection, interventional clinical trials were being designed with appropriate study design, and they struggled to find out how to present a favorable risk and benefit ratio. While all aspects of the life were at hold at the start of COVID-19 emergency, ethics committees received a large number of COVID-19 research studies, and the expectation was that ethics committees should be able to review these research studies with competency as well as with efficiency. While communities were living in fear, in despair, and with uncertainty, it was hard to find out how to obtain effective informed consent. It was not known how to deal with therapeutic misconception as well as humanitarian misconception. At the time passed and knowledge of preventive strategies improved and vaccines were developed, it seems challenges move from micro level to macro level. Question of individual preferences versus global public good emerged. Vaccine access was planned, debated at length, and then it was challenged by inequity. Existing vulnerabilities worsened. Scientific community as well as political leadership, they were expected to work in collaboration while maintaining their distinct roles. So we have put together this workshop, which is to examine how to do research during global health emergency and to review the preparedness and response. The principal objective of this workshop is to examine these challenges, look at the varying levels of preparedness and response, and learn from each other and find out how to go about doing research during emergencies while keeping our commitment to ethical conduct of research. The workshop includes opening presentations by leading experts with diverse range of experiences around 3 identified themes. These themes include research in global health emergencies, preparedness and response, global health emergencies and ethical issues, and ethics review during global health emergencies in Pakistan. These presentations will be followed by question and answers, and the aim is to generate discussion to learn from one another's experience. And based on this learning, look for a common way forward on how to integrate ethical research and global health emergencies. Later part of the research of this workshop would have a focus on Pakistan perspective as an example of low and middle income country. And we will focus on what is the role of ethics committees in this perspective in a low resource setting. It is an honor to be joined by Ms. Catherine Wright, Assistant Director, Newfield Council on Bioethics, London, UK, and Dr. Elif Emeki, International Chair in Bioethics, WME Corporation Center, History of Medicine and Ethics Department, Medical School, Tobe University, Ankara, Turkey. And I'm delighted to have Dr. Saima Iqbal. She's Chairperson of Research Ethics Committee of National Bioethics Committee of Pakistan, Shifa College of Medicine, Islamabad, Pakistan. In addition to this, I'm delighted to note that we have been joined by other respectable colleagues with an interest in research, ethics, and emergency research, and the ones who have made leading and notable contributions in these areas. It would be an honor to have participation of Professor Amir Jafri in our discussion. Dr. Amir is professor at Center of Biomedical Ethics and Culture, SAUT, Karachi, Pakistan. We look forward to participation of Mr. David Curry in this discussion. He's leading a global foundation focusing on governance, ethics, evidence, policy, and practice. Let's invite Catherine Wright as our first speaker for today. Catherine has been Assistant Director at the UK-based Newfield Council on Bioethics for over 14 years. During that time, she has been responsible for a number of in-depth inquiries exploring the ethical implications for policy of development in biomedical research, including most recently an exploration of how research can be ethically conducted in emergencies. Earlier projects included the ethical inclusion of children in research, the donation of human bodily material for treatment and research, and the care and support of people with dementia. Before joining Newfield Council, she worked in UK Houses of Parliament, providing politically neutral briefing on health policy and law, the English Department of Health, revising policies on consent, and within the National Health Services, advising on human rights law. Please join me in welcoming her. Thank you.
Good afternoon, and it's a real honour to be able to join you for this discussion of, I think, a very timely question of how we can conduct research ethically in global health emergencies. I'm delighted to have the opportunity of sharing the work that we've been doing over the last 2 or 3 years at the Newfield Council on this issue, and I'm looking forward even more to the discussion in life, or at least in Zoom, rather than pre-recorded, when later in this symposium we're able to discuss and explore some of these issues together. I'm also looking forward very much to the other presentations. So moving slides on. So to start with a little bit of background, who are we? And the Newfield Council on Bioethics was set up back in 1991, 30 years ago. We're based in the UK. We're a small independent body, and with a remit to inform policy and public debate about the ethical questions raised by biological and medical research. So with this role, we occupy a very similar space to a National Ethics Commission, which many other countries have. The UK doesn't have such a body, and there isn't a government-sponsored body taking that kind of role, which is why the Nuffield Foundation back in 1991 decided to set us up. And since then, we've been funded equally by the Foundation, by Wellcome, and the Medical Research Council. And because we have this independence from government, that gives us the freedom to identify topics that we think are ethically challenging, whether or not our Department of Health might agree, for example. On the other hand, I think we have to keep demonstrating all the time with the quality of our work and what we produce that our recommendations should be listened to. We don't have that automatic sort of government placed status, as it were. And one of the other factors of being an independent body rather than a government-sponsored body is that it means our remit can, if appropriate, extend to issues of international concern. We're not specifically bound to consider only UK or European issues, though a lot of our work inevitably does focus in that area. But if we feel we have something useful to contribute and we're able to work in a sufficiently inclusive way, we do have the liberty to look more broadly at global issues. So back in 2018, in light in particular of the ethical challenges that emerged during the West Africa Ebola outbreak, our council decided it would be appropriate for us to look at an explicitly international issue, the question of how research could be conducted ethically in such emergencies. And in framing this question, we identified that there was a real dilemma here. On the one hand, good quality evidence is essential for effective emergency response, both now in the midst of the emergency and in future for future emergencies. But on the other hand, emergencies are highly non-ideal circumstances in which to conduct research. And I'll come back in a moment to particular ways in which the circumstances are so non-ideal for research. So back in 2018, we set up a 2-year project supported by an international and interdisciplinary working group, including members from China, India, Uganda, Liberia, Ghana, and Brazil, as well as UK-based researchers with partners in many other countries. And this led in January 2020, ironically just 2 days, I think, before COVID was declared by the WHO to be a public health emergency of international concern, to the publication of a detailed report with policy recommendations and with what we called a call for action to funders and to others to help support ethical research. And just to highlight there a theme I'll keep coming back to during this talk, I think a big theme of our findings and of our discussion was that how many other players there are, apart from researchers and ethics committees, who have a duty and a role and are able to help support research to be ethical, or indeed whose actions may make it very difficult for research to be conducted ethically. So while most of our recommendations were at the level of policy, they were to big organisational or governmental stakeholders, and we also provided materials to support researchers or ethics committees on the ground, drawing on the report, for example, through the development of an online course through the Global Health Network, which has been supporting WHO's epidemic ethics work. We're very alert in this project as to quite how important our working methods would be. If we were claiming that a project run from colleagues in the UK was to have relevance and usefulness for people working around the world, it was crucial that we found appropriate working methods and were sensitive to context, including, I think, working out recommendations in ways that could be played out differently in different countries. So a quick introduction to the working methods for this 2-year project. We had input from researchers, from emergency responders, and from participants, including the leaders of Ebola survivors organisations in Liberia and Sierra Leone, and also, of course, from policymakers from over 30 countries. And if I just skip to the next slide, and have an idea of the spread of the people who contributed and had input into our project in various ways. So we had diverse contributions through an online call for evidence, as well as holding meetings in the UK to which we invited people from many other countries. And in fact, they actually flew in, which seems extraordinary now when we've all got so used to operating on Zoom. We also had, we worked with partners to have meetings and discussions in the Philippines, in Singapore, in Lebanon, and in Senegal. And we also linked with international conferences in the US and China, who brought together people working in this field to share our emerging findings and discussion and get even wider input that way. One of my colleagues conducted a number of literature reviews looking specifically at community experiences in very different kinds of emergency, in the Indian Ocean tsunami, in the triple disaster in Fukushima in Japan, in Hurricane Katrina, and in the Syrian civil war, to really try and understand the bottom-up experience of responding to emergencies. And then, in addition to our international working group, we had a very international external review process with, I think, 12 or 13 different reviewers from around the world commenting on the working draft and then drawing their comments into the final version. As I've touched on already, our findings and our recommendations focus very much on the ethical implications for policy, what policy stakeholders such as governments, such as research funders, such as international organisations might need to take into account, as well as the ethical conduct of individuals on the ground actually doing the research or being involved in the research in some way. And we're very alert to the crucial importance of context, how the implications for policy may play out and be relevant in different countries and in different kinds of emergency. And we very much see this report as a starting point for further discussion. In fact, when we first were about to publish, we'd initially hoped to be able to work with partners to hold meetings in person in each of the 5 different WHO global regions to explore precisely these kinds of questions as the next part of the project, as it were. And of course, COVID put a stop to that, which is why it's been a particular pleasure to have this invitation and the chance, I think, to have a similar kind of discussion with you today. So thank you again for that opportunity. So some preliminary questions that we had to tackle as a working group before we even really sort of got to grips with how we might think about framing an ethical framework or ways of thinking about the challenges and emergencies ethically. And those were what's different about an emergency. We have to be very wary of being exceptionalist about emergencies and claiming that the usual rules don't apply. And secondly, I think a really important question, what counts as an ethical issue? And I'll come back to that in a moment, because for me, that was one of the most important aspects of this project. So starting with what's different about an emergency, we took a very broad approach. We didn't limit ourselves to what is called a public health emergency of international concern by the WHO. We know that itself is a contested term, and the circumstances in which it's declared can be contested. So we looked at emergencies described as global health emergencies or humanitarian crises or complex emergencies that might include, either separately or in combination, infectious disease outbreaks such as Ebola, Lassa fever, Zika, and of course COVID-19, natural disasters such as earthquakes, tsunamis, floods, and human-made disasters, whether those are industrial accidents, conflict, or the results of conflict or climate change in the form of mass displacement of peoples, and so on. And while clearly in some ways these different forms of emergency pose very different challenges, they also share some really important characteristics. And we felt it was these that were particularly important in making research particularly challenging ethically. So these characteristics include a disruption from some kind of stable norm, not necessarily a very good norm, but nonetheless a disruption from the normal way of life. Great health need, both at individual and population level. We don't talk about a pandemic of the common cold. We do, of course, talk about a pandemic of a disease as threatening and as infectious as COVID. Importantly, the time pressure to act and how that can be in real tension with the normal timescales and normal ways we work in research. And coupled with that, questions of uncertainty, particularly when we don't necessarily feel we have the time to wait for greater certainty before we move forward to the next stage, because that might possibly have more harm, be more harmful than moving forward in the level of uncertainty that's facing us. And then finally, again, a point that I really want to bring out, I feel is really important, about recognizing the human impact of emergencies, the distress inevitably be caused both by the disruption to our lives, by the threats to our health, by what's happening to our families, our society, our ability to earn a living. And I think all these issues have been illustrated so clearly by COVID, how that actually affects how we work and how profoundly ethical the dealing with that distress is. In a global health emergency where these kind of factors transcend country borders, there's an additional ethical challenge in the scope there is there for tensions between the many different parties involved, over tensions over control, over responsibility, and over legitimacy, about who's making decisions, about who's calling the shots, and how people cooperate. And that might apply, as for example, in the West Africa Ebola outbreak, where a number of countries are affected, but many more countries, many more international organizations all pile in as part of the response, and you have those different kind of inputs. Or indeed, as in COVID, in a genuinely global emergency where potentially every country in the world is affected. And just to capture some of the ethical implications of that complexity of the number of stakeholders, we pulled together this very simplified diagram, just trying to map some of those who were involved, who had a stake. So starting with the affected communities at the heart, we look at the role of national governments, of course, ministries of health, research organizations, local health services, and indeed sometimes also the military or others who get involved in logistical aspects of emergency response. Then going anti-clockwise around the diagram, we look at the role of international organizations at both headquarters and at regional levels, such as the WHO, other parts of the United Nations, and so on. And they can support national governments and coordinate emergency planning and response, and also have a more overall strategic role. There are the role of humanitarian non-government organisations, both international ones, Médecins Sans Frontières, International Red Cross and Red Crescent, International Rescue, and so forth. Also, of course, really importantly, local humanitarian organisations. There are regional and international research networks and how those intersect with local national networks. There are the non-commercial research funders, the big international, often UK, US, European-based ones, which brings extra challenges, I think. And then finally, there's the private sector. I'm just going to move my little picture there. The private sector, which helps fund emergency preparedness in all sorts of different ways, through partnerships with intergovernment agencies and others, and also fund research through pharmaceutical and biotech sectors. And the reason why I draw this out is that I think if we think about all those different players, and we think about the accountability that researchers should be having to all these different players, ideally, it will be in the order listed in the slide. So the first accountability ought to be to affected communities themselves, those who are being asked to be research participants, those who are having to deal with the emergency. Secondly, it should be national governments and others who have legitimate authority in the jurisdiction, and that would include national ethics bodies. Then we also need to think about how researchers interact with other parts of the research sector, other important parts of the emergency response, including the intergovernmental agencies, the humanitarian sector, and the many private sector actors who may be involved. And then, of course, there are their own employers and their own funders. But in practice, we know that perhaps inevitably, accountability will go first to the people in that last bullet point, to the employers, because we all feel accountable to our employers, to funders, because that's where the money is coming from. And there's a real challenge here, I think, in thinking about how employers and funders can actually set up systems that support researchers to be accountable in this much more holistic way, rather than just looking out of the emergency, out of the country in question, to those who are employing or funding them. We had some very interesting feedback on this diagram from a similar meeting we had a few months ago, partnering with colleagues in Guinea, who made the point that affected communities have been placed at the heart of the diagram, but we haven't actually identified there the key roles that affected communities themselves play in responding. That's something we highlight, I think, very strongly in the report, and I was really struck that it hadn't worked its way through to the diagram, that somehow we've missed a trick there. So I just wanted to highlight how important that is. And then looking beyond traditional research ethics, thinking about how we think about research much more broadly. Health-related research in emergencies often takes place in the context of deep historical inequities and ongoing imbalances of power. Indeed, neglect can actually be a root cause of some emergencies, for example, where people don't have access to health services, where there aren't good diagnostic and services available to them, and what might have been a very containable outbreak of some kind becomes an epidemic because of that lack of care in an excluded population. Even where that isn't the case, it's generally the most vulnerable, the most marginalised people who are most impacted by the emergency. And I think, again, we've seen that very clearly in the way COVID has had a particularly strong and detrimental and difficult effect on those who are already most vulnerable, who are already most excluded. And yet it's these groups who are least likely to have any influence on what research gets done, where it gets done, or how it gets done. So we argue that this provides a really strong claim for thinking about what you might call macro ethical questions, even political questions, in particular about who has power and influence and how that power and influence should be exercised, as well as the more traditional, you might call micro questions of trial design, review, recruitment, and consent. And of course, those questions still remain at the heart of ethical research, but we need to look at these bigger picture questions too, and urge our major stakeholders to do so as well. And this has implications for community engagement, for how those who might be affected by the research have been engaged in it throughout, for fairness and international research collaborations, for better support for frontline workers, and for many others. So moving on then to the ethical considerations that the Working Party drew on in order to come to its recommendations. And our working group developed what we called an ethical compass to guide decision making, both for those on the ground who are face to face with the non-ideal circumstances I've just described, but importantly also for those at policy level, to try and prompt things that those at policy level need to think about and act on to enable those on the ground to ensure that their research can be conducted ethically. And the three core values in the compass emerged from the evidence and experience people shared with us during the project. And I'd really like to emphasise, these values were not identified top-down by mapping existing approaches to research ethics, though I'm pleased to say they are highly compatible with many of the related frameworks. But they very much emerged bottom up from the input we received. And in particular, if I can speak about my own experience of being in this project, a workshop we had in Senegal looking at community engagement and involving the Ebola survivors leaders from Liberia and Sierra Leone, I think set the tone for the whole of the project. I literally went home after that workshop, had a sleepless night, and thought we had to rethink, we had to reframe how we've been thinking about some of these issues to really make sure that participants were and their experiences were at the heart. So just to go around the compass in turn, starting with helping reduce suffering. This is the fundamental reason why research is being conducted in the first place in an emergency. We're not just doing research because it's interesting, research for its own sake, and we're doing research in order to enable us to respond better, both in this emergency and in the future. And there's some really important questions here of power and of perspective. Whose suffering are we concerned with? Who's defined that suffering? Whose perspective is there? Are these actually the most important needs? You might have what seems a very useful and important research project, but if that research project crowds out another even more important one that addresses an even more important question to those affected by the emergency, then maybe that's not the right project to be doing. Second, respect for others as moral equals, or equal respect, as we've abbreviated it on the slide. And this links with the question of who's defining suffering, and hence how we prioritise research goals and thinks about who matters in these circumstances. It prompts us to ask how communities will be involved in planning research, how studies can be designed in ways that are sensitive to local values and local traditions, and how we can be confident research participants are treated respectfully throughout the whole research process. I think in traditional research ethics, we're very good at thinking about that at the point of consent, but we're perhaps less good about thinking about what respect means all the way through the research project, right to the very end. And then fairness, considered in a number of ways. So in terms of distributive justice, looking at the benefits and burdens of research and how these have been distributed, and also in terms of discrimination, who's being excluded. Thinking about fairness in terms of process, are the processes used seen to be fair? And then in terms of working relationships, particularly between international, national, and local researchers. I think it's really important to recognise that these values may at times be in tension, and there will be no easy answers to the ethical dilemmas that arise. However, none can simply be overridden. We can't simply go in and say, let's do the research this way, it's the most effective way of helping reduce suffering, without thinking about how we also take account of how we are respectful and how we are fair. Sometimes it may simply not be possible to do research at all because of the difficulties of the emergency situation. It may be simply impossible to conduct it in ways that are even minimally fair or respectful. But when we come to these decisions, when we balance how we somehow meet to at least an acceptable degree each of these three domains, we need to include consideration of the opportunity costs of not doing research, of the suffering we may not be alleviating by not finding out how to help people better. Not doing research isn't always the safest option, even though sometimes it may be a necessary one. So having sketched out this way of thinking about some of what is at stake ethically in emergencies, we went on to ask ourselves the question, who are the duty bearers? Who has a duty to take action in this context? And we identified three ways in which one could ground a duty to take action, and which brought in this much bigger policy picture rather than simply burdening researchers and ethics committees with the whole burden of supporting research to be ethical. So the first of those were those who have the greatest ability to act, those who actually have the power. And that, I think in many cases, will be research funders who hold the money and decide how to give it out, what stipulations to place on it, how to expect accountability, and so forth. And also governments who actually make research possible or not possible in many different and complex ways. Secondly, we thought about those who have a particular relationship with others. In particular, that would be the employer-employee relationship. So it seems fairly obvious that how a research institution treats or behaves to its directly employed researchers will have an effect on how those people can act. We also emphasize that it's not just about a direct relationship. There may be many people involved in the research who are being contracted. They may not have an employee relationship with a research institution or with a funder, but there's still responsibility there, particularly in terms of, for example, safety and so on, thinking of the way that frontline workers in research and emergency response can be at risk. And those who are employers remotely, via contracting arrangements and so on, need to bear that responsibility and not simply pass it on to a third party. And then thirdly, and this may apply more to some kinds of emergency than others, thinking about those whose actions or failings have actually led to a degree of culpability in connection with the emergency. One example there might be negligent failure to prevent an emergency happening or negligent failure to mitigate the effects. And where there are stakeholders in that case, they have a particular responsibility to act responsibly. So we draw on this compass to look at policy implications across 6 broad aspects of research. We talk about a more inclusive approach to influencing the research agenda and priorities, and also a more inclusive approach to study design and review. We look at the question of consent and what part that plays in what we call the wider ethics ecosystem, thinking about other aspects of research that are needed to support consent practice. So not all responsibility is borne by the person giving consent. There are responsibilities for others too. We think about equitable collaborations and partnerships, particularly between in partnerships in different countries with different power relationships with different amounts of money. We think about respectful and equitable sharing of data and samples. And finally, we look at questions of support for frontline workers. In this session, I don't have time to go through all those in detail, but I'll be very happy to come back to any particular aspect that you'd like to draw in the discussion. What I'd like to do in the rest of this presentation is to look first at the key recommendations for researchers and for research ethics committees, and then to take that step back to look briefly in the last few minutes at the recommendations we make to policymakers. So starting with implications for researchers and ethics committees. And first and foremost, we highlight the importance of community engagement. And at best, this engagement should be there from the very beginning as the study develops. Our recommendation to ethics committees is that as a minimum, they should expect researchers to have engaged with communities in the development of appropriate communication tools and consent procedures. Ideally, I think as ethics committees, as researchers, we would like to see engagement much earlier than that, but that should be a minimum. Secondly, we need to look really closely at questions of inclusion and exclusion criteria. I think we're very good at thinking about the risks of inclusion, both physically and also psychologically, for example, in terms of stigma or putting people at other forms of psychological harm. But we're often less good about thinking about the risks of exclusion. So in social science research, that would be a question of silencing voices and not hearing particular perspectives because we think they're too vulnerable to reach out to. In interventional research, there are real risks of those new interventions not working in particular groups. And again, if we think of COVID, some of the questions around what data was available on the impact of the vaccine on older people or on pregnant women, both of whom, in fact, it's really important they're able to protect themselves against COVID. So we argue that vulnerable groups should not automatically be excluded without further consideration. We shouldn't just say they're vulnerable, we can't include them. We need to draw on local knowledge of what the risks of both inclusion and exclusion are to determine fair inclusion and exclusion criteria. And we suggest that ethics committees should expect clear justifications for any exclusion criteria that are being set. Thirdly, we need to get consent right. So one of the first questions we ask ethics committees to look at is whether the proposed consent processes are the best and most sensitive that are possible to achieve in the circumstances. And while emergencies are difficult circumstances in which to conduct research, we know there's an awful lot of work outside the emergency context of ways of sharing information in ways that those who are in distress, those who are very unfamiliar with research can understand, and they can make a decision that actually follows their understanding. However, in the extreme circumstances of an emergency, I think we have to recognise that realistically people may have few choices. And in some cases, The answer to will you take part in my research will be yes, whatever the circumstances, however good your consent process, because people may simply feel they have very few choices. And in those cases, we suggest it's really important to think about additional ways to ensure that participants are shown respect as moral equals. We must seek consent properly because that's about being respectful to the individual and their decision. But we can't put all the burden of responsibility on their yes. We also have to make sure that as researchers, what we're doing can be justifiable. And for example, that could include the way that community members have been involved in developing the research, thinking back to the importance of community engagement. The more involved those who are actually affected by the research have been in developing it, I think the more confident we can be that this study is really meeting local needs and is sensitive to local concerns. And then recognising that consent is important, it's central, but it isn't everything. It doesn't justify anything we do as researchers. We suggest a final intuitive check, to ask ourselves, given all the circumstances, can we say it's fair to ask people to take part in this study? Can we say it's a fair invitation when we ask them to do so? And then finally, there's a really practical issue that comes up over and over again and has come up over numerous projects I've done in recent years, but it seems so often to be neglected. If we're asking people to take part in our research, invest their time and emotional energy in answering our questions, quite apart from any physical risks or burdens they may be running, we do owe it to them to tell them later what we've found out, how they've contributed to future knowledge. So we've asked funders to make clear that there's ring-fenced funding for this as a routine part of making grants. We also suggest it's a key issue for ethics committees to address with researchers, inviting them to describe their communication plans across the lifetime of the research when they're being asked to authorise studies. So moving from those at the sharp end, researchers, ethics committees, finally looking at the role of research funders, national health and research leaders, and regional and global institutions, such as the regional and central offices of the WHO. So starting with what research funders can do. We argue that they have a duty to engage collaboratively with national governments and with research leaders on research priorities. So there should be an end to parachute research, a phrase I kept hearing over and over again during this project. We need to embed expectations of community engagement in grant-making systems. We heard from funders who said, we like community engagement, we think it's a good thing, but we don't actually give a grant, a budget line for it unless somebody asks specifically. We felt that should be their responsibility to highlight the need for this and make sure funding is allocated. Funders need to require researchers to work collaboratively with response services to ensure that participants' basic needs are being met. I think some of the hardest descriptions we had of challenging research was where researchers were approaching participants in good faith for an important study to discover the participant's situation was just so desperately bad, no food to feed their children and so forth, that it was completely inappropriate to approach them. There's a real responsibility here on funders to require their researchers to make sure that they can make those referrals, that they're working in partnership with others so that that doesn't happen. And finally, we need to promote more equitable collaborations in research, or funders need to promote more equitable collaborations in research, including long-term investment for institutional capacity strengthening. Moving on then to the role of national health and research leaders, we suggest that they have a lead role in setting research priorities for their countries, collaborating with regional and global actors as needed, so taking their role in making sure that the research taking place in their countries is not parachute research, it's actually responding to local needs. Taking their part in this idea of the close intersection there needs to be between researchers and responders to make sure that participants' needs are being met. There's obviously an important role there of national health and research leaders to make sure that those connections are in place. And then long-term investment in structures that facilitate community engagement. That was one of the clear messages we got from Liberia about the importance of where community engagement and the systems have been put in place during the emergency, how those can be there for the long term to make things work. Then moving on to the second slide, thinking of long-term investment in research capacity, particularly at organisational and institutional level. It's one thing to have people go away, perhaps to other countries, to get PhDs or masters, but they need jobs, they need to be able to do that work within a country. So stable funding is needed for academic departments. We need systems of research governance and regulation. We need national guidance on the use of data and samples. because researchers need all that structure around them. They can't create that for themselves if there isn't the national input into doing it. And then we need support for research ethics structures, both day to day, just how ethics committees have the funding and the support and training they need to operate effectively, but also thinking for planning collaborative approaches in emergencies and how, for example, we can avoid the situation where 10 different ethics committees are all having to look at the same study. And we need ways of actually doing that in an organised way centrally that has local legitimacy. And then linking with this idea of local legitimacy, there's a real leading role here for national ethics bodies, particularly in the challenging circumstances of an emergency. Because in emergencies, there are difficult trade-offs. There may be circumstances where no one answer is good, but some are least bad. And only a body with local legitimacy, such as a national ethics body, can make those kind of calls. And then finally, as we've moved up, as it were, the level of stakeholder, the more and more remote, thinking of the key role of regional and global institutions, thinking of their role in supporting research priority setting at the start of an emergency. And that's something the WHO, I think, has been doing a lot more in the last few years, first in the DRC for Ebola, and then at the start of COVID-19. And also supporting development of collaborative approaches at regional level so that it's possible to have rapid and responsive ethics review in emergencies. And again, we're aware of very good practice in that field, for example, from the Pan American Health Organization in South America. And then there's a final cross-cutting theme that picks up all these different stakeholders, which is about the ethical imperative of preparedness. Some things will always be difficult in emergencies, but others can be planned and prepared for if there's political will to do so. And this involves having resilient health systems, because without those, we can either respond effectively to the emergency or do the research that's necessary. This includes capacity strengthening and research, rooted in local infrastructure and with community involvement. And also at a much more explicitly ethical level, in terms of foreseeing some of these ethical challenges and planning how to support those who have to deal with the ethical decisions on the ground. And what that support might look like is likely to be very different in different places. That's something that needs real local input to identify and develop. So finally, just to highlight the call for action that we published at the same time as our report in January 2020. And this was an attempt just to highlight what we felt were the 4 real headline recommendations that funders, governments, humanitarian organisations and others with influence should take account of. And that was this crucial point about funders working in partnerships with governments and with others such as the humanitarian sector to ensure that participants' basic health needs were being addressed through the response effort. We felt strongly that was a minimum requirement for research to be ethical. Investing in community engagement mechanisms in the long term, promoting equitable collaborations, particularly between research partners in low and high income settings, and finally supporting emergency planning, including robust health and research systems. Thank you very much indeed for listening, and I look forward very much to meeting you online shortly and being able.
Thank you so much, Ms. Catherine, for the wonderful presentation. I just love the idea where you have mapped key stakeholders involved in the global health emergency and putting the community at the heart of it, at the center of it. So I cannot agree more. We do have a few questions for you, but I would like to take a note here that we have been joined by our participants who are virtually, as well as there are a few participants who have joined through the conference rooms within the hospital. So we will be receiving questions from them. So I would like to thank all the attendees and all the participants. Here, I would like to take 1 moment to thank our IT team, as well as my colleague, Exclusion, who is behind the scenes. So we would be happy, and we encourage all the participants to post their questions. We will try to answer all of your questions at the end of the presentations, or if not possible, we will try to take these questions at the end of the presentation, at the dedicated section of discussion at the end of this workshop. So, but however, we would like to have all the questions answered. So that is what we are aiming to. So feel free to post your question. We are keeping an eye on all the questions. So just that you know. So here I would like to take first question from, yes. So this is my colleague, Dr. Mariam Hassan. She's a clinical researcher from Pakistan. And let me read out her question for you, Ms. Catherine. So this is basically community engagement has remained a challenge throughout this pandemic, globally regardless of context. Can we discuss the factors that make effective engagement especially difficult during this pandemic and the possible solutions going forward?
A really excellent question, and thank you very much for your comments, Mariam. Yes, I mean, I think we learned a lot during the Ebola crisis of really imaginative ways of doing community engagement. And I think this is where I think I mentioned the meeting we had in Dakar during the project, which involved the Ebola survivors leaders and also the community engagement lead from Liberia, and how powerful that was, and being alert to just what participants and communities brought in terms of understanding research and the importance of that constant engagement. And of course, despite the fact that obviously Ebola was a very infectious disease, there were different scenarios there, and that it was possible in unaffected communities, for example, to meet publicly. And there's a lot of talk there about meetings in person. I think one of the really interesting challenges, obviously, from early on in COVID was the fact that almost the entire world moved quickly into physical distancing, and how that impacted on community engagement. I'm not speaking here from direct experience. I'm linking with work I know that have been going on by others. So I do put that as a proviso. But I'm aware, particularly from colleagues in Africa working in Kenya, for example, that there has been a lot of innovative work, obviously moving online. But I think in particular being alert to the fact that not everyone has access to smartphones, or I think it's very easy to move into the Zoom way of thinking about things, and we've all done that very effectively. But then missing the fact that that really excludes really quite vulnerable populations potentially. So I know a lot of the work that was done and with colleagues in Kenya was also about ensuring that they had parallel systems with just using mobile phones and other forms of communication to hear people's perspectives. There is a website called MESH, which I think is an international global project funded by Wellcome, which shares lots of really interesting initiatives, different ways of doing community engagement during COVID. So sharing different examples of good practice from around the world. And I'd be very happy to just dig out that link and pop that in the chat or in the Q&A after we've just had this question and answer session, because I think there are people who, unlike me, have been doing this on the ground for the last year or so. I think the other thing that's really interesting, just to reflect from my UK perspective, is I was really struck at the start of COVID and discussions I had with our own Health Research Authority about our report, and about, and it was put to me, surely in an emergency there isn't time to do the kind of engagement we normally do. And the UK regards itself as really quite, I think, innovative and enthusiastic about involving patients and wider communities in engagement. And I pushed back quite hard on that, saying this is exactly the point when you do need engagement, and it's not difficult to find out who's affected. We're all affected. So in a sense, it's a very wide pool to draw on. And actually, I think we moved very quickly from engagement having dropped from, I think, 80% of involvement of wider publics in research proposals down to about 20%. And then within a few months, it went back up to 80% with a lot of work from our Health Research Authority in supporting that. They even provided a sort of online matchmaking service so they could link researchers to people who were willing to comment on studies if they didn't have those kind of local connections. So I think we had, certainly at UK level, we had this sense of, gosh, it's actually us being affected by an emergency now. And I don't think we have had that experience before. It's always very comfortably been about other people. And the first reaction was not to engage. And then the second was to actually find ways of doing it even more effectively. The other quick thing I think I'd like to add to that was an insight from the Liberian Ebola community engagement research lead, who was, I think, again, very powerful in our report. And he had a sort of phrase that, you need to learn and adapt and learn and adapt. Inevitably, you won't have the perfect systems in place. Ideally, there'll be systems or structures in place. You would start with that kind of discussion as you develop your important research. We know in practice that isn't going to happen, or at least not without future planning. So we have to make the best of what we have, and in particular, be flexible enough in our studies so that if we do get feedback saying this is really problematic, we don't just say, well, how interesting, well, I'm afraid the protocol's been agreed by the Research Ethics Committee and we can't change it. We need to have ways of being flexible and going back. And I think this idea of learning, adapting, and making sure when we plan our studies, we allow space to respond is one of the ways we can deal with the uncertainty of research. But I also know on the ground it is actually really difficult, and it's much easier to talk here on the Zoom call from my kitchen making those comments. Thank you for the question.
Thank you so much. So just a small further thought on this, or maybe a question. I find this concept hard. Is there an effective way to measure community engagement? How do we say that community engagement was sufficiently done or it was not sufficiently done? I find it so hard. Is it just a perception, or is there a way to objectively measure it? Because I feel it's my ignorance maybe. So I would like if you could just elaborate on that and help me in understanding if there is any way we can sort of objectively measure it. Thank you.
I think that's a really good question. Again, I'm afraid that's beyond my area of competence, I'm afraid. I mean, I would imagine there are people working on measures of how to evaluate community engagement. And again, I mean, I will have a quick look after this talk. I'll have a quick look on the MESH website and see if I can find some links there, because I think that's a very good curated collection of ideas of good practice and work in the field. So I think they would hopefully be shared there if they existed. I think there's the other thing in emergencies, I think I touched on in my talk, sometimes we can't do things ideally, so we do things as well as we can. Recognizing that not doing research at all may be worse because we're not actually finding an evidence base for what we do. So sometimes doing it imperfectly will still be better than not doing it at all, in I think a very pragmatic way.
Thank you so much. Thank you so much for this comment. And here I would like to invite other panelists if they would like to contribute to any of the ongoing discussion. Just let me know and I should be able to have their comment. So we have received a couple of questions. So let me take our second question. So we have received a question from Fatima Kushi. She is a clinical research officer in Shaukat Hospital in Lahore, Pakistan. So she's asking, during public health emergencies, how essential elements of informed consent should be adapted or modified, considering the limited information available on risks and benefits?
I think inevitably the consent process used will have to reflect both the circumstances in which consent is being sought. For example, if you're not always seeing people face to face, depending on the kind of study and physical distancing, and also what we know about the risks and benefits. So I think there are two main things that I'd like to reflect on from what I said in my talk. The first is that we have a duty to make our consent process as good as we can. And yes, the circumstances are difficult, but there is a whole host of good practice of people who have been doing research for many years in circumstances where people are not familiar with research, where they may be in very difficult circumstances, and where finding ways to explain meaningfully what's involved in the research, respond to the problems of the therapeutic misconception you referred to earlier, and so on. And we need to draw on that. But I think drawing on some of my own past work, again on consent, I think sometimes we risk confusing an appropriate seeking of consent with how we document it. And certainly in the UK context, we get so fixated on consent forms and all the written information and so on. Well, actually consent is about someone having enough information to make a decision. How we document that, whether it's in the form of a signature, whether it's a recorded voice, whether it's simply a record in the patient's notes that on a particular day a certain conversation was had. All those documentation questions are different from actually the seeking of consent itself. So yes, we need to seek consent as well as we can, but we need to reflect on how aspects of that might look different because of the emergency context. But also, yes, if we don't have the kind of level of certainty about risks and benefits, and obviously in any research we don't have certainty because that's why we're doing the research. But the nature of the emergency might mean that we're moving forward faster, perhaps, than we might otherwise wait for more evidence to appear before we move to the next stage. And we have to be frank about that with our research participants. But I think the other thing I'd like to say on this, or the other side of that, is, again, I think one of the common misunderstandings about consent is if we have consent, it's okay. And that puts potentially too much of the burden on the participants. It's saying that they're having to take all the responsibility. I think we as researchers, as research ethicists, as others in the field, we have a duty to be confident that what we're asking them to do is fair. I think this almost intuitive sense, is this a fair thing to ask somebody in these circumstances? And the consent is part of that fairness, but our own knowledge at this point in time of risks and benefits is another aspect of the fairness, and the extent to which local people, those who are being affected, have actually been involved in developing this study, I think is also part of the fairness, because the more people have been involved at a local level, the more it's answering a question that's locally important. I think the more we can become, we can be less worried then about being exploitative. If this is a study designed somewhere else that might or might not affect us, and we've just been added in as another site, I think that's when one gets more nervous about how ethical that's going to be.
Thank you so much, Ms. Catherine. Thank you for elaborating. So I'm just informing all the participants and attendees that we have noted all the questions. I'm not following a very particular order, but I'm just using some of my judgment. I'm sorry to take few questions earlier, and because I believe that there are certain questions which will be best suited at a later point of the workshop. So I'm noting that for the later part of the discussion. So just for the information. So here I would like to take one more questions. So just to inform that, because we have good time duration with us, so we would be slightly flexible, and we can take time for question and answer, and then we can move to next presentation. So we are taking some liberty to ask as many questions as possible. So I would like to take this question here. It is Dr. Raja Sachar, and he has asked that public health emergencies are manipulated and used to avoid certain procedure, ethical consideration, and speedy approval of research proposal. So I would like a comment from our panelists to this comment. So Ms. Catherine, what is your take on this comment?
I think that highlights why strong ethics review processes are so important. Because yes, I think we can be put under pressure to be told, this is so urgent, we just have to move forward with it. And actually, I'm involved in an international group called the COVID-19 Clinical Research Coalition, the ethics group there. And colleagues from, example, Chile and the Philippines have talked about the kind of pressures they've had effectively just to approve vaccine trials. And while they felt they needed to give proper consideration to risks and benefits, and whether, for example, placebo is an appropriate comparator, given we now have licensed vaccines and so forth, and the pressure from governments just to move forward. And I think that's one of the reasons why we developed the ethical compass. That was partly about saying, governments, funders, you have these duties too. You should be thinking about how your policies and practices actually affect ethical research. But it also, I think, at an international level, hopefully, may give some external authority to say, we're not comfortable with this. We feel we're being manipulated. And look, the WHO has this guidance, the Left Field Council with this global inclusive process has produced this guidance. So perhaps an individual ethics committee who may feel vulnerable to that degree of manipulation then has perhaps some pushback to say, no, in the circumstances, we don't think this is fair, or we don't think this is respectful. I don't think that means that ethics committees shouldn't be speeding up their processes and being flexible and trying to meet in 2 weeks' time by Zoom rather than whatever the routinely the standard meeting agenda might be. We need to find ways of being flexible and responsive in our processes. But the actual core of what we're doing, for all the reasons that Dr. Raja raises there, it's really important that we push back on being manipulated.
Thank you so much. So while we do have other questions, I would like to ask one question from all the panelists as well as all the attendees. So in case you are encouraged to use the chat function, but at the same time, if you would like, we can try and request our IT team if they can unmute the ones who would raise their hands. So feel free to raise your hand and raise your hand, and we can try to unmute you. So the question I would like to ask all the attendees and the panelists, during this pandemic, do you love your job or do you hated your job? And if you would like to elaborate it further, if you loved your job, why you loved your job, and if you hated it, why you hated it. So I would like to receive the answers in the chat box, that is okay. If any of you would like to raise your hand and go vocal, we can try to do that. So I'm looking forward to your responses. So it would be great to know. Let me know who can go first. Any of the panelists?
I'm happy to go first since I'm unmuted.
Please
and
do that.
Fellow panelists. I think I would say a bit of both. I think it's been a very strange time for me professionally, in the sense of, you know, literally 2 days before COVID was declared to be a public health emergency, we had published this report, you know, which had been 2.5 years' work. I'd spent, you know, I don't know how many hours over time, sort of over the period up to January, finalising the report and getting it published. So to see its relevance, you know, to see it being used in the WHO guidance and other guidance, you know, and hope it has really been of value in you know, what has been an extraordinary time for the whole world, you know, has been nice, if that's the right word. At the same time, I think the thing I found really distressing, and you know, this is obviously separate from my work, but it ties in very much, is seeing how almost one's worst fears about how you know, global corporations and governments have behaved in response to COVID, you know, all the language of solidarity, all the language of the things that we try and put forward in our report about shared responsibilities. And yet, you know, we've seen the kind of vaccine, you know, hoarding and priority taking, and that, you know, I find it very distressing and humiliating as someone who lives in the UK. So I've on a professional level, I found both those things challenging. Personally, you know, it's been the whole questions of working from home for 18 months and these kind of things. It's both been difficult, and I've also been aware of how fortunate I am that I can do that relatively straightforwardly. One of the strange plus sides is actually how much more international collaboration I've been able to have, because we've all got so used to Zooming like this. I think that's been one of the very strange benefits many of us have had from the pandemic, of just being able to communicate like this. And of course we could before, but we just didn't think to do so. So just a few odd reflections there, and I'll hand over to my fellow panelists. Thank you.
Thank you so much. So thank you so much. Well, I would let our other attendees and participants, maybe they can use chat function to respond to this question. At the same time, we have few raised hands. So I'm hoping that we should be able to unmute them. So Mr. David Curry, he has raised his hand. So David Curry is president of GE2P2 Global Foundation, a US headquartered NGO with a mission to advance ethical resilience and scientific rigor in research and evidence generation across health, human rights, humanitarian action, education, and development. The foundation has particular interest in how research proceeds in challenging contexts, including conflict, post-conflict disasters, and complex emergencies, and how adaptable ethical framework in these contexts can serve and protect individuals and communities involved in research activities. So, Mr. David Curry, you have been unmuted, so we are looking forward to hear from you.
I'm going to talk now. Thank you so much, Farah, and thank you so much, Catherine, for a wonderful overview, very concise. Two impressions that I took away that I thought I would share, because there's much more of the program to go. Threaded throughout the Nuffield report that you provided the overview to, in my notes, I kept writing down the word agency. And by agency, I mean the empowerment, the perception and the reality of those who may be involved in research in the context of emergency being given equitable and active participation. And I did note your slide, which I think was headed duty bearers, and I wrote down immediately rights holders in terms of what right holders actually deserve and should insist on. So I very much appreciate it. Indeed, in making a quick note about your ethics compass, it struck me that perhaps in the center, there's a hexagon which might suggest agency as having a critical and central role in thinking about what a compass should be pointing to, or what perhaps might be at the center of the compass. The second quick point is the very important observations around flexibility. In other work we are doing, the note I made to myself was adaptive trials. In the clinical trials world, as I'm sure you are well aware, and most of the participants are, there is a concept which is somewhere beyond emerging, but is still being refined, of adaptive trial design. And of course, this is referring to an approach where a protocol is intended to be conducted as planned, but there's provision made and sort of an anticipatory posture that as the trial unfolds, it may well suggest certain flexible options that can to some extent be articulated in advance and to some extent cannot. It struck me that I'm not sure I've heard a great deal about how adaptive trial design might be more strongly integrated into the thinking of researchers and those designing protocols in emergency context. Perhaps I was not listening closely enough, but it seems like your use of the word flexible might be able to encompass that. And the last quick point is I guess what I would call it is, I would call it the fog of research. And by that, I mean that even the best designed protocols, research projects that have fully engaged the community, et cetera, are occurring in an increasingly complex set of sometimes competing research activities. Some of them may be health related or very specific to reducing suffering and the most pressing needs of those who might be in an emergency context. But some may be far afield, like researching how, drone delivery efficiency, or I'm thinking about another example of certain disposal techniques for medical waste, or 26 other things that may be important at some level and in some context, but add to the general noise that those who are most vulnerable in these emergency contexts may face, essentially competing research projects and priorities, some of which are very directly linked to the most immediate challenges of security, protection, nutrition, et cetera, and some which are frankly on the edges, which makes me think that if there is one precautionary principle that should be overarching, it's to try to assure and to make sure ethics committees are empowered to ensure that the research that is being proposed is indeed needed and is best performed in the stressful context in which it's proposed. So thank you for the opportunity to make a few observations. And thank you again for a wonderful presentation and for all the work that Nuffield has done and continues to do. Thank you.
Thank you so much. So with this, we have another participant who would like to go vocal here. Dr. Rajesh Sachar Askar, he's Director, Administration, Punjab Human Organ Transplantation Authority. And we have unmuted him and looking forward to his comments.
Very good afternoon to all the panelists and the participants. It's a good discussion going on. I want to share that I love my job during this pandemic because I was there to help the people. So being a part of the medical community, we were the only one which were not locked down. We do not have to think how to use our spare time. It helped me to learn and at the same time to get the new experience to acknowledge the suffering of the people and feel a sense of achievement. Okay, I am helping the people, I am helping my community and helping the other people, and at the same time also feel blessed, and I am thankful to the Allah Almighty who has saved us from this pandemic. I was not the one of the patient, I was there to help them, and I was on the giving and not at the you can say I was not at the suffering end. So that's why I love my job during the whole this scenario.
Thank you so much. Thank you so much, Dr. Sachar. And with this, I would like to make a comment that we have noted all the questions which still remain unanswered. we would take them up, of course. We'll try our best to take most of the questions. So here I would like to move on to the next presentation. And for that, I would like to invite Dr. Elif Emigi. Dr. Elif graduated from Ankara University. She completed her PhD in History of Medicine and Ethics. She was a Forgetting Fellow in 2013. So I would So Dr. Elif has been a Forgetting Fellow in 2013 and 2014, and she had her master's certificate of research ethics training fellowship at Harvard University. She is currently head of ILD at the top university in Ankara. She established UNESCO Bioethics Unit at top university. She is a member of World Association of Medical Law. And we are so fortunate to have her with us. So she would be giving us an overview of the diverse ethical challenges that we face during public health emergencies, during this emergency, during the past emergencies. So I would like to go to Dr. Elif's presentation.
Hello. Today I'm going to talk about the ethical implications of COVID-19 pandemics, and I'm going to discuss on the need for a global ethical stance for public health emergencies and what we have not learned since plague to COVID-19 pandemics. So to begin with, the COVID-19 pandemic has once more driven our attention to the concept of public health emergencies and how it is perceived in public health ethics. World Health Organization defines public health emergency with an international concern as an extraordinary serious event that has the risk to spread internationally and therefore requires immediate, coordinated, and collaborative international response. This definition constitutes the essence of international health regulations published by the World Health Organization in 2005, and is a product of the long history of communicable diseases which negatively affected huge numbers of people from various countries by causing millions of deaths, hindering international trade and travel. Although IHR 2005 was a considerable milestone in the international preparedness and response to public health emergencies, several concerns were raised regarding its effectiveness during SARS and Ebola pandemics. One of the concerns was the absence of core values and principles which would guide ethical decision-making during public health emergencies. The lack of an ethical framework has been one of the main concerns in terms of response and management of the COVID-19 pandemic, both locally and globally. So today I'm going to begin with a short look at the history of international preparedness and response to infectious diseases and identify the factors that led to IHR and its revision in 2005. Then I'm going to talk about ethical shortfalls of 2005. IHR 2005, which were identified in recent pandemics and discussed largely. And I'm going to end with a discussion on the possibility of a global ethical stance to address the ethical issues of public health emergencies that threaten the sustainability of humanity. So let's have a look at the short history of infectious disease outbreaks and international response. The plague was the most significant communicable disease which caused public health crisis in medieval times. Individual states generated some public health measures like quarantining ships for 40 days before allowing them to draw close to the ports, ordering people to stay in their households, or robing physicians with special clothing that covered their body and face to avoid contamination and miasma. However, it was soon understood that none of these measures were sufficient to stop the spread of the plague. Worse, new communicable diseases continued to emerge, letting humanity despairing about the limited effectiveness of the standalone local measures. So epidemics of communicable diseases like cholera, yellow fever, and the plague, with the devastating consequences on many people, could not be taken under control by national quarantines and continue to breach international trade and health. And this urged countries to collaborate to stop the transport or dissemination of communicable diseases. And with this objective in mind, the first International Sanitary Conference was held in 1851 in Paris, and 13 other conferences followed the first one. And the main paradigm of thought in these conferences was that countries should be transparent about outbreaks of cholera, yellow fever, and the plague within their borders, and inform each other to facilitate surveillance and response. In this context, it was thought that regional institutions might facilitate generating and implementing measures against communicable diseases dissemination and response. And some organizations were established to organize regional efforts like Pan-American Sanitary Bureau and like. And with the establishment of the WHO in 1948, these regional organizations became less significant, and the WHO became the leading actor for organizing the cooperation and coordination of communicable diseases spread, and the regional offices of the WHO took over the functions of the regional institutions. So the first international sanitary regulations were released in 1951 by the WHO, and the name ISR was changed to IHR, which we also use today, International Health Regulations, in 1969. And the, again, main paradigm of thought was very similar to that of the 19th century, which was based on obligations of states to notify each other about outbreaks and restrictions of international trade and travel in their territories in case of an outbreak. And in addition to this historic perspective, the HR had another drawback. It contained a very limited list of notifiable communicable diseases, which only included cholera, yellow fever, and the plague. And later, two other communicable diseases were inserted in this list: the smallpox, which was removed from the list in 1981 due to global eradication of the disease, and the typhus. However, despite the new additions, the list was becoming more outdated by novel outbreaks like HIV/AIDS and the reemerge of archaic diseases like tuberculosis and malaria. And another shortfall of IHR was its limited perspective regarding complex factors like migration, urbanization, social determinants of health, and economic inequalities, which have both causal and reciprocal relationship with the spread of communicable diseases. In addition, with the beginning of the new millennium, the public health emergency term acquired a new dimension, which is bioterrorism, and microbiological agents were started to be used as means of terrorist attacks, which had the capacity not only to kill or disable considerable numbers of people living in the region, but also risk the lives of and well-being of individuals who live in remote areas. So public health was also threatened by nuclear disasters. The Chernobyl accident in 1986 was a warning to humanity that public health emergencies were not limited to communicable disease outbreaks. The existing IHR did not have any reference to these newly emerging threats. With this in mind, the revision process of the HR was initiated, and a paradigm shift that aimed to portray public health emergencies as an issue of global health security guided the revision of the process. And the new paradigm conceptualized public health threats as a set of risks to global health emerging from biological, chemical, nuclear, and environmental origins. With this paradigm shift, public health emergencies were no more limited to a set of communicable diseases originating from a particular geographic region and can be controlled by transparent surveillance, and limiting international travel and trade was left behind. This paradigm shift and concept of global health security required a new global health governance system. The new governance system, which was reflected in the revised IHR, contained the following main differences in terms of ethical values and perspectives. The agents who were responsible for providing information on surveillance of outbreaks were enhanced to include non-state actors, such as NGOs. the private sector and the media. And this approach was indicating that maintaining global health security and managing preparedness and response to public health emergencies is a responsibility of all parties, including individuals. The extension of responsible agents for reprising outbreaks endorsed the principle of transparency and promoted the timely flow of information for public health threats. The extent of measures enhanced also. The old version of the IHR suggested implementing a maximum number of measures for international trade and travel, where the new perspective endorsed a scientifically proven risk assessment to determine the limits of measures. This change highlighted the principle of proportionality to determine the limits of measures. And the essentiality of scientific knowledge in decision-making and the custom-made approach to public health risk. The list of diseases was also replaced with the concept of global health security, and the SARS epidemic in 2003 provoked this amendment, which clearly showed that list of diseases and syndromes will not work when an outbreak with a novel agent is taking place. With the new global health security concept, the scope of the AHR expanded significantly to cover all possible sources of public health threats. Balancing greater good for public health and individual human rights, the HR 2005 intended to oblige parties to implement minimum interference with human rights and international trade and travel that is necessary to protect the public health. However, despite these new changes and the huge paradigm shift from the previous health regulations, we discovered that there are still significant shortfalls, ethical shortfalls in the IHR 2005. Although it had a wide perspective regarding global health security and preparedness and response to public health emergencies, the epidemics of 21st century like AIDS, H1N1, Ebola, and SARS led to scrutinizing its effectiveness. It was beyond discussion that the IHR 2005, an agreement among 196 members of the WHO for building capacities to detect and report public health emergencies, was one of the huge steps for developing global early warning and response system and planning, preparedness and response against public health emergencies. However, the IHR 2005 had several limitations. Among them, one particular deficiency precluded its effectiveness and practicability. And it's this one that I'm going to tell now. The IHR 2005 did not provide any ethical guidance to decision-making, since it does not contain any reference to ethical principles or moral values that should be considered during a public health emergency, and also for pandemic preparedness and response. And the importance of this sufficiency was revealed during the influenza pandemic in 2007. Individual states and the global health community realized that decisions during a public health emergency were mostly value-based. And these value-based decisions were essential in terms of building trust and compliance with public health measures during the crisis. Having this in mind, some institutions, including the WHO, published ethical guidelines for pandemic preparedness and management. In the ethical considerations in developing a public health response to pandemic influenza report, the WHO defined critical ethical questions after influenza pandemic, like the distribution of scarce and essential resources like medications, vaccines, and intensive care unit beds, obligations of healthcare workers to the community considering the risks to their health and the health of their households, and balancing public health measures like quarantine, surveillance, and social distancing with individual rights and freedoms. In this document, it was clearly stated that pandemic preparedness should include an ethical framework for decision-making to answer these questions, since it would be too late to develop one during a public health emergency. However, these guidelines did not gain enough attention from public health authorities, hence, like the HR 2005, none of them could offer proper ethical guidance during the current pandemic. On the contrary, the current COVID-19 pandemic revealed the fact that the global health community and individual countries, regardless of their level of socioeconomic development, were not well equipped for noticing and reflecting on moral issues and value-based decisions faced during the pandemic. Humanity was caught unprepared and failed to respond timely and adequately and mitigate the devastating consequences and impact of the outbreak. So let's have a quick look at the ethical questions during the COVID-19 pandemic. The current pandemic showed that the main questions which require a frame for ethical decision-making during the public health emergency arise in different settings and various decision-making levels. So this is the first thing that I want to emphasize today about the ethical questions during the current pandemic. There are various decision-making levels and in different settings that have ethical implications. So these different settings vary in a wide spectrum, with healthcare facilities on one hand, like hospitals or primary healthcare units, and global health and international health governance on the other side of the spectrum. And value-based decisions during the pandemic in a healthcare facility are listed as, let's say, allocation of scarce resources such as medicines, preventive measures such as vaccines or special treatments units like intensive care beds or personal protective equipments. Apart from allocation of resources, there are other ethical questions as well. Like the limits of the ethical obligation of the healthcare workers to serve when there is scientifically proven high risk for their health and well-being, as well as the health of their families or people they live with. Or another ethical problem, the breaches of physicians' freedom to choose the appropriate treatment for their patients because of the obligation infused by authorities to apply treatment plans with little or no scientific proof and obliged by public health authorities. Another one, the limitations on healthcare workers' freedom to quit or withdraw from their jobs because of high demand for their service. The obligation to serve in communicable disease treatment, which may not necessarily be their area of expertise, and the inevitability of overlooking their patients whom they were in charge of for the sake of COVID-19 pandemics. So these are some of the ethical problems, ethical issues that arise in healthcare facilities during the COVID-19 pandemic. At the national level, let's have a look at the ethical issues at the national level. Public health authorities are in charge of making value-based decisions at national level. And the ethical tension at this level is usually between individual rights and freedoms of individual citizens and the greater good for the community. The execution of public health measures that limit individual rights, such as quarantine, social distancing, or wearing masks, is justified because there is scientifically proven evidence that they will ease the dissemination of the outbreak. The legitimacy of such sanctions has been debated largely during the COVID-19 pandemic. The responsibility of health governing bodies to promote well-being, health, and security for all people, and the transfer of some authority of individuals to public health authorities in terms of the social contract were suggested as grounds for legitimacy of the authorities to overlook individual rights and freedoms in extraordinary circumstances like pandemics. On the other hand, a considerable amount of people found it hard and unnecessary to comply with these limitations, and several public protests were done in various countries all around the world against these public health measures. These protests may provide empirical evidence that public health measures which infringe individual rights should be well planned before a public health emergency takes place. And while planning a response to public health emergencies, the authorities should be transparent about the possible measures that will limit individual rights, but still will be needed. I mean, these measures, although they limit individual rights, they would still be needed to control and manage the emergency. Also, having community engagements in these preparedness plans would enhance public compliance and the effectiveness of these measures when the crisis arrives. The shortage and unjust distribution of vaccines to some low and middle income countries has driven attention to the importance of ethical decision making at the global level. So first I talked about the ethical issues at the level of healthcare facilities and at the national level, and now we're going to have a short look at the issues at the global level, ethical issues of decision making at the global level, and vaccine distribution of allocation of vaccines is one of them. Questions about the justification of the ethical responsibility of high-income countries to share their resources with low-income, low-resource countries have been raised. Solidarity and justice are among the ethical themes which were argued for justification of obligation. However, this ethical discussion is even more deepened with the arguments about the vaccine passport. The lack of an ethical stance in terms of global health inequalities makes room for such proposals with risk to worsen the conditions for low or middle income countries and increase global health inequalities. There is also another particular decision-making level that has implications at both healthcare facility level and national and global pandemic management level. That's research ethics. The vast need for scientifically proven knowledge urged the research community to conduct research immediately. And this urgency provoked discussions about the role and responsibilities of ethics review committees or institutional review boards. You can call them institutional review boards. In some countries, it's called IRBs. In some countries, they are called ethics review committees. So I'm referring to both of them as synonyms. Again, several guidelines have been published to assist the ethical review process. However, the questions about the IRBs working processes were still discussed widely during the COVID-19 pandemic. And apart from these ethical questions, some other problems have ethical implications that require ethical stance are the limited executive power of the IHR 2005 and the WHO in terms of leading international response and coordination, unawareness of changing and newly emerging vulnerabilities in a national and international context, and recognizing the right to health as a fundamental value of pandemic preparedness and response, and failing to refer to the right to health of all human beings while advocating for mitigating inequalities are foremost issues in this context. Bioethics is, as we all know, is considerably a new discipline that has been flourishing since Potter used the term in bioethics in his book, Bioethics Bridge to the Future in 1971. And the term bioethics has been welcomed broadly because it offered a wider perspective than medical ethics discourse and invited an interdisciplinary approach to ethical issues which may have an impact not only on human beings but on all beings in the world. Potter, as you would remember from his book, listed 5 major factors which carry the risk of that at risk sustainability of life, which are poverty, population, war, pollution, politics, and the negative side effects of progress. He plausibly argued that the new discipline of bioethics should bring science and philosophy together to produce wisdom, which he defines as the knowledge of how to use the knowledge. So by revisiting Potter's thoughts, we can be inspired about the role of ethics in public health emergencies. Even decades ago, Potter pinned the idea that the issues which may risk life and well-being were global. And note that his list constitutes of universal problems with socioeconomic and health consequences for all humanity. The phenomena in this list are global in origin, hence they can be solved with global awareness and response. The ethical questions which surfaced during the current pandemic have supported Porter's perspective by underlining the need for a global ethical stance. However, considering the ethical questions and dilemmas that were faced during the COVID-19 pandemic, we can say that humanity has difficulty understanding this fact even now, when SARS-CoV-2 virus is threatening the lives of millions of people all over the world. Pandemic preparedness and response require bringing together the science and ethics to generate wisdom needed to guide policies and priority setting. The COVID-19 pandemic made it clear that, first, we can say, the problems faced in different countries are universal, and no country is immune to them regardless of their economic status. The second thing that the COVID-19 pandemic made clear is that countries must cooperate and demonstrate acts of solidarity to overcome these problems. And the third thing is decisions during a pandemic are driven by both science and ethics. On the other hand, the idea of finding global solutions to global problems and request for a global ethical stance invoked some criticisms about the dominance of Western values in global settings and turning a blind eye to the ethical codes of communities and countries by imposing Western values to them. So some critics call this a new form of neocolonialism, and therefore refuse the concept of global ethics as it threatens their communal values and autonomy. The proponents of this critical state this critic state that Western culture prioritizes individuality, while non-Western cultures find it inherent value in the community, find the inherent value in community and the greater good. However, this criticism contains a paradox that refutes its basic argument about the impossibility of global ethics. The paradox lies in the general assumption that all individuals in Western or non-Western countries share the same values, and that community is a homogeneous living being with a single set of ethical codes. This thought might have been pertinent for some closed communities without any access to effective communication means with the rest of the world, but not in the current time, which there is a continuous interaction among people regardless of where they live. So this interaction makes it easier to understand and share the values of individuals and communities from a common understanding about problems and possible solutions to them. Hence, it's plausible to argue that the ethical values and principles of different communities might converge to agree on some common values, and the higher risk for all humanity's well-being brought by the pandemic can be a facilitator for this convergence. So this was my presentation about the ethical issues and need for a global ethical stance in terms of public health emergencies and the pandemic, the current pandemic that we are all going through. Thank you for your attention.
Thank you so much, Dr. Elif, for emphasizing different ethical questions at different levels. And thank you for highlighting the need for the framework of ethical decision making. Very important. So we have a few questions for you. So I would like to take this first question. This is from Sheher Bani from Clinical Research Office of Khanum Hospital, Lahore, Pakistan. And let me read out this question for you. As respecting individual liberty or right is essential element of ethical, how we can make sure it during health emergencies in which every individual is in need of treatment becomes interfering or competing the presence of other individuals. So she would like to know how to make a decision when there is a conflict between personal preference or the public good. So how would you like to respond to this?
Yeah, thank you for this question. In fact, we don't have an answer to this question. That's why we're discussing all these issues. You know, when there's a public health emergency, the tension is always between individual rights, freedoms, preferences, and the common good. In ethics, we think that the individual rights, preferences, and decisions, the individual's autonomy is the most important factor when making a decision on behalf of the patient, when patient is making a decision for her. However, when we are talking about public health emergencies, we have to think about common good, and maybe more focusing on a utilitarian perspective and an individualistic perspective, because every decision and every action that individual takes has an impact, has a direct impact on public health and common good as well. So when an individual refuses to quarantine, for example, or refuses to be vaccinated, or wear a face mask, it's an autonomous decision for herself, but it has direct impact on the health of the other individuals as well. So this needs some kind of a balancing and also some kind of specification, I guess. Not only balancing, but also specification, because public health emergencies have shown us that this kind of extraordinary times require reframing and redefining some of the values and principles that we use in normal times. Because in normal times, you know, I mean, apart from public health emergencies, we are familiar with these norms, like respect for autonomy, or providing, you know, providing benefit or avoiding harm, and so on and so forth. But when there is the public health emergency like pandemic, and if this public health emergency is coming from a novel microorganism that we don't have really no idea, no scientific knowledge, no scientific proven knowledge, then this is a very chaotic environment. I'm not saying that in these kinds of chaotic environments we should overlook all ethical values and, you know, just focus on common good. On the contrary, I'm saying that we should be aware that the content and the specificity of these values and principles vary during these times, and we have to be aware of that, and we have to be flexible enough to redefine them, and to find a balance, not to overlook some particular values that may harm the human dignity and individuals' rights, but also, you know, serve for the best of the public as well. So this is a very difficult question. I don't think that there's a real answer to this question, but I think there are some ways to find answers to this question. And considering all the public health emergencies that we have been facing as humanity, you know, in every 2 or 5 years, we are facing some kind of epidemics or pandemics. Maybe they weren't as big as the COVID-19 pandemics until now, but we have been going through these public health emergencies, and we have experienced. But when COVID-19, the pandemic occurred, we weren't really very well prepared, although we were working on pandemic preparedness and response programs. And I think no country is immune to that. We all failed to some extent.
Thank you so much for highlighting this. And our next question that I plan to read out for you is around the same point, I believe. So this is Dr. Raja Sachar, and he's asking that considering the global health security, did we perform better in COVID pandemic as compared to previous pandemics in terms of management of emergency and ethics? Do you think that concept of global village appeared to be fake, as every individual country was making decision of their own, and he's further of the opinion that seems like the poor countries were neglected, they were not taken care of. So I would like to have a comment from you.
Thank you for the question. In fact, I think I just answered some part of this question. I think we all failed to some extent. And, you know, before we had the vaccines, there were some initiatives to support the development of vaccines and to make sure that every country has equitable access to the vaccines like COVAX. But, you know, when the vaccines were available, we saw that that kind of solidarity didn't work. And I also observed this kind of you know, unsolidarity among my colleagues as well. You know, before the vaccine, all the colleagues, like not only ethicists but also specialists from various scientific backgrounds, they were really eager to come together and to discuss the ethical and scientific issues and how to overcome this problem and so on and so forth. And when the vaccines were available, people from countries who have direct access to vaccines were, you know, they were in some kind of a mood that, okay, this pandemic is over, because now we have the vaccines, now we have the effective protection, and we can go back to our normal lives. But this was a reality for only a handful of countries. Other countries were facing all the devastating effects of the pandemic still. However, the understanding in the countries which had access to vaccines was really very different. So where was the solidarity, and where was the, you know, global village, and we can't be safe and everybody is not safe, and we didn't see them after the vaccines were available. And we failed once more, I think, because we all realized that, you know, we thought that when we are vaccinated and then when we have a certain amount of vaccination ratio in our community, we would be safe. However, that's not the case. You know, in countries where there is not sufficient vaccination available, those countries, those people, is still a risk for the other part of the globe as well. So even from pure utilitarian perspective, I mean, even from the perspective that just thinking for ourselves, we should be valuing the equitable access to vaccines. And from my perspective, I mean, this is my personal view, humanity has to learn to be in some kind of a solidarity and to leave aside the national interests and to see that the pandemics or any other kind of public health emergency or big risk that has the risk to humanitarian existence, we have to work together. And ethical values are not a fantasy that we can think or consider when it is available to us, and just leave aside when it is not working for our interest.
Thank you so much. Very true indeed. So as we have heard that if one fails, we all fail. So this is very important, that we all need to be successful in responding together. So I would like to make a comment that we do have a few questions. I would be saving few of the questions for the later part. So here I would like to ask one small question to all the attendees. I've already posted that in the chat. So I would like all the attendees and participants and the panelists to respond to this question. I would like to hear from all of you. So I am assuming that most of us are connected in one way or the other with healthcare or with ethics, as physicians or as ethicists. So was there any chance that when you find yourself working outside of your working place and outside of your working hours, so not on your job, but doing the job of a healthcare professional or a ethicist or the role you are in. For example, a chat over the dinner table maybe, or at a public place where you felt like that you felt a responsibility to raise your voice. So I would like to invite comments from all of the attendees, and I believe we do have a participant who would like to respond to this. So we have unmuted our participant, so I would like the participant who has been unmuted to kindly introduce yourself briefly and then respond to the question. Thank you.
So hello, this is Sadia Hassan from Clinical Research Office, Shaukat Khanum Hospital, Lahore. So yes, indeed, most of the time I used to do work out of hours and out of workplace, even doing home chores. I needed to respond to a call or had to reply emails on priority basis. So yes, we had to work out of hours and out of station most of the time, and most of my colleagues did also have same sort of experiences.
Thank you, Satya. Thank you so much for responding that we all had long working hours. So can I hear from any of the participants that while they were not on job, they were in their busy, in their personal lives, but there was a point when they felt that there is a responsibility for them to respond, while not specifically on their jobs, maybe a chat over dinner table, and you felt like that you have to advocate for vaccines or maybe for inequity. So thank you so much, Sadia. Can we have any other responses? I would be happy to unmute other colleagues as well. So do we have a volunteer here?
Yes, I'm Asim Farooq from Clinical Research Office at Shaukat Khanum. And yes, I would like to add it here to Ms. Sadia's point that I think one of the main reasons that we have had to advocate or speak up for vaccines and not even like out of our offices is the problems that are generally considered to be associated with vaccines in the general public. So even though the government was had given enough communication through social media and through telecommunication about the benefits of vaccine, there were always some doubts in the society and in the people, specifically among the females regarding their pregnancies and stuff like that. So we had to, although we didn't have any particular information on it, but we still had to advocate for the vaccines and specifically the research that was going on for the vaccines, because it was important to have research on this. And another major thing that I usually found in WhatsApp groups was that people were asking, like, it took so many years to develop polio vaccine or some stuff like that, but we have a vaccine for COVID within 6 months or within 1 year. So how is this possible? And is this actually a vaccine, or is this even a disease? Because I think in Pakistan we have also faced this issue of rejection of this disease, because people don't think that this even is a problem for them. So yes, these were the points that we had to talk about on our dinner tables and in our groups, where people were questioning the research or the need for vaccine for this specific condition.
Thank you so much, Asim, and thank you so much, Satya. So yes, it has been true that there were many conspiracy theories and there was misinformation that led to uptake of the cures which had no scientific evidence or scientific basis. There were myths which were circulated at mass level, and people were believing that led to vaccine hesitancy, that led to the problems with mental health as well as physical health. So very rightly said. So I have received a written comment, is like a question or a case. So I would like to share it with all of you and take the opportunity to discuss this further. So let's consider an example. Consider a mysterious disease affecting people in a small village. A large number of people get affected with this disease. It was hard to diagnose, and it has high mortality rate. Relevant authorities reached there to help. They investigated the cases, and by doing so, they took some blood samples. After some point, researchers also wanted to have a closer look, and for that purpose, they wanted to have access to the existing specimen, existing blood that has been received earlier for making a diagnosis. So my question to all of you is that, do you feel, is it okay to reach out the affected community for this research? My second question is, at this point in time, what would be the challenges in connecting with these patients and their families and asking for consent? So it would be a very awkward consent while we cannot offer them any knowledge or any benefit or any hope, but we are asking them to participate in research. So do you think a waiver of consent is rather better in this case? So I would like to hear from panelists, if any of the panelists would like to respond to this, or if any of the participants would like to respond to this. It would be great to have comments on this case. Thank you. So, may I ask if any of the panelists would like to give a comment on this, or?
I'm sorry, Elif, I had a slight connection problem, so I only half heard the problem. Is it that the village is affected by a serious illness and the research is nothing to do with that illness?
So basically, they are building new research to find out about the disease, but at the moment, they do not have any knowledge about the disease as well as what can work in this case. So they have anything to offer in terms of hopes or any effective treatments, but what they are trying to know is, they're just trying to fish, maybe. So at this point in time, the question is, do you think it is appropriate to reach out to affected community for research purposes? And because in that case, it would be hard to connect with them while they are suffering with a mysterious disease. And there is no hope, and there is uncertainty. And as researchers and in healthcare professions, we cannot offer them anything in return. So because the consent would be very hard in these cases. So as a further question, do you think that it is okay to think that a waiver of consent is justified in this case, because the researchers would like to make use of the existing specimen which were obtained for diagnostic purposes? So
I think that's such an important question, and I think if we think back to the very early emerging signs of COVID, similar questions must have arisen when literally it's a disease we don't know why people are dying. We have diagnostic samples. I think it links with another question I spotted in the chat earlier about how we communicate about research meaningfully, because I think in a sense, the challenge here is that it might seem very, very, very remote to what people are suffering. Hence my question about the connection between the research and the illness. And yet, it may be we can't offer any hope, but we certainly can't offer any hope if we don't start researching and understanding and characterizing the illness. So I think one could argue that the research, if it's been properly conducted and it has some hope of providing useful knowledge about this new disease, could be morally justified. But I think then there's the second question about just whether one directly seeks consent, whether one seeks some kind of community level consent in explaining why this will be done and the protections there will be. So in order for us to learn about this disease and possibly in the future, but we don't know, find some way of helping treat it, we do need to participate in this research, but these are the safeguards that will be put in place and so on. I think what that might look like will actually be context dependent. I'm not sure you can have one single answer. But I think it should be about recognizing that people have a stake in what happens with their blood sample. That can't just be disregarded, however important the research might be, but finding what's in a contextually appropriate way of getting, whether it's community level consent or individual or simple notification that we've had to do this for these reasons, but these are the very good safeguards we put in place. And I think a number of those factors. Thank you.
Thank you so much. Thank you so much for answering to this question, because it has to be context specific and we have to take in consideration multiple factors. And this is important, that how we approach this difficult situation. So with this, I believe Dr. Elif would like to add to this.
Yeah, I agree with Catherine, and I would like to underline a few issues. When there is a public health emergency with an unknown disease in a closed community, I'm not really sure about the validity of the assumption that people would not like to take part in a research that would benefit all the community. Because I think in times of crisis like that, especially in small closed communities, the solidarity, is much more important, and people feel that they have to do something both for themselves and for the community to overcome this problem. So I'm not really sure that if we are doing the right thing, if we are assuming that taking consent would be hard, because people will not really be having any individual benefit from the research, or may not, let's say. Having said this, there are two issues. The first one is about privacy and confidentiality. We're talking about specimen that is collected for purposes of diagnosis or public health measures, and now we're going to use them for research. And if we don't inform people, maybe not individuals, but as Catherine said, some kind of a community level information that this specimen will be used for research purposes, then this means that we are violating the privacy and confidentiality of the population, with the argument that we can provide some kind of benefit to them, and I think that doesn't balance out. And the second issue is that when you are not transparent about the measures or the things that you are doing for the sake of providing benefit to the community as public health authority, you lose confidence at some point that even though you're doing right things, people don't comply with the measures that you are trying to establish after that. I think during public health emergencies, in crisis and chaotic environments, the public health authorities should be transparent, although the news that they're going to disclose is not good news. I mean, this is treating community with respect. You can say that, yeah, the source will be scarce, they're scarce, we don't have enough for everybody, we have to sacrifice, but that's the reality, and we have to face this all together. So we will not make that we are providing everything to everybody and we are doing the best. No, if it is not possible to provide for everybody, then we have to sacrifice. And community, has to know that's because of respect to the community. And when you lose your transparency, when you talk behind a veil, then people begin to question every measure that you try to implement after some point. And I think maybe the vaccine hesitation, maybe it depends on some kind of losing confidence and trust to public health authorities because they weren't transparent maybe in the first step. So I think, yes, we should get consent, even not individual consents, but from some kind of a community consent should be taken.
Thank you so much, Dr. Arif. So approaching rightly, and maybe being sensitive to the context, and we should try to connect with the community with respect. And this is one way of building trust from the initiation of the process. So I would like to take one more comment from one of the participants, and after that we can move to the last presentation. Dr. Saima, I'm sorry for keeping you waiting for so long, but I'm doing it for a selfish reason. I want to have a focus on our perspective, the Pakistan perspective, and I would like to use more time for that. And I'm just sorry. So let's just take one more comment from one of the participants who has been unmuted, I'm informed. So I would invite our participant who has been unmuted to share his comment, please.
I think Dr. Alif has clarified many things, and he has given a very comprehensive answer to your ethical question. As far as I know, every research proposal have a need to be ethically and scientifically very strong enough. If your research proposal is scientifically sound, that is the first ethical requirement of any research proposal, then definitely you will be able to engage the community. Against the communication with the community and engaging the community leaders and communicating with the presumed benefit of your research, what is going on, how that may be benefited in the far future, but benefits may not be available as early as possible. I think we will be able to convince the community. I think without the consent, without the participation of community, everything is going to be wasted, and your efforts will be more laborious, and no results will be used. As well as the samples utilization is concerned, I think there's still ethical debate is going on all over the world if we can use the sample for the other purpose or not. I think if these samples are going to be used linked with the same disease, and if they are going to generate an scientific evidence that is linked with the same disease, that may be used. Otherwise, I think we must need consent of the community on this issue.
Thank you so much, Dr. Sajjad. And just to add that we have received very comprehensive guidelines for the use of specimen for research purposes, and that is a focus as well as on emergency setting that has been prepared by National Bioethics Committee of Pakistan. So it's a document worthy to read and to get guidance on questions like this. So lastly, I would like to invite Dr. Saima Iqbal. Dr. Saima is chairperson of Research Ethics Committee, National Bioethics Committee of Pakistan, Shifa College of Medicine, Islamabad, Pakistan. And National Bioethics Committee of Pakistan, they have taken a leading role in responding to this emergency. They have been there to make the guidelines that we needed at institutional levels, at the levels of our institutional review boards. This is a group who have done notable contributions in terms of supporting the ethical conduct of research, and they have upheld their tradition during this emergency as well. And we were always looking towards them for guidance and for all the difficult questions. So this is my pleasure to invite Dr. Saima for her presentation. So I would request my IT team to kindly play Dr. Saima's presentation. Thank you. I think we should be able to connect to the presentation in a moment. Okay, So I believe there is some problem in making the presentation played. So may I ask Dr. Simon, is it possible for you to share your screen? Can you do that, Dr. Simon? And maybe we can.
Okay, I let me.
I'm sorry for the trouble, and I'm hoping that my IT team should be able to facilitate Dr. Simon to share her presentation with us, to share her screen with us.
Is my presentation visible?
Yes, it is. Kindly make the presentation note. Thank you so much.
All right.
Thank you.
So I can go ahead. I just hope it runs. But okay. So thank you, Dr. Farah and organizing committee for giving the Research Ethics Committee of the NBC a platform to discuss ethics review and our challenges of dealing with these ethics review during the last 2 years, 1.5 to 2 years. So my outline of the presentation is such that, again, a little bit about public health emergency research. I know Catherine has talked about this already, but mine is a bit more simplistic. So I won't take too long on that. I'm going to be talking a little bit about the context of research within Pakistan and how our working at the REC level was in pre-COVID times, how we adapted to COVID times, and some unique challenges that we faced, and some of the cases that we saw. I will not be taking any names of organizations or institutions that were involved, and these cases that I'll be discussing are available on the NBC website. So I'm not breaching any privacy or confidentiality. So Catherine talked about how public health emergency research was different from conventional research. And I'm just kind of recapping what she had said earlier, and this is more simplistic. So we talked about public health emergency research being fast-tracked. There is a lot of uncertainty. There is a lot of limited information. People are not clear about what we are doing with. We are all groping in the dark. National bodies like the REC were also, we were not clear on so many things. And one of the biggest challenges is that treatment versus research. What is treatment? What is research? Those lines are blurred altogether. There were no established standards of care. People were desperate. There was an element of desperation all around because we wanted to save lives on one hand, and we also wanted to generate information, but that information had to be valid and scientifically sound information, and we had to differentiate it from hype. So there was also an element of coercion in the sense that we wanted people to come into the research, understandably, because we needed information. So so involving people in research, yes, there may have been some coercion. You need to understand that we work in a fractured health system. The context is such, and our sample population in any public health emergency will always be vulnerable. And, I thought it interesting, and maybe we can take it later on, Catherine, defining vulnerability. What do we mean by vulnerability? And can there be multiple levels of vulnerability within our context and in Pakistan? Because we live in a hierarchical society. So is the whole of Pakistan vulnerable or just certain communities? So it would make for an interesting debate. And identifying communities itself, because communities are also hierarchical. So will you engage with the communities differently? So probably we'll leave that for discussion. So you need to understand that whenever you're doing public health emergency research, you need to have lots of good clinical trial sites, and you need competent researchers and research teams. Your community engagement, as I said, needs to be meaningful. And, participants, your sample, as I said, they're vulnerable. Their capacity or their freedom to give informed consent may be compromised. So as someone in ethics governance, you need to keep that in mind. And of course, such research is also costly, and we've seen a lot of funds which were diverted away from other projects towards emergency research. There is more scrutiny of public health emergency research in the public eye. Expectations can be unrealistic. And of course, unlike conventional research, there is a lot of political pressure and there is a lot of media pressure that you have to deal with. So just a little bit about our context in Pakistan. So how much is Pakistan contributing to global research? You need to understand Pakistan is low middle income country. And we have limited resources, and especially our health budget and budget for research is also limited. Most of our healthcare expenditure is out of pocket, and a lot of healthcare is being provided by the private sector. So keeping that context in mind, you can see how much there can be manipulation by the private sector, or maybe lack of oversight, ethics oversight. So, I found this diagram interesting about how much of a contribution has Pakistan made in the last one and a half year or so in research. And if you look at the yellow part, life sciences or health research, we haven't made much of an impact, although we are improving. But again, compared to the world, we are not, one of the main producers of valid or scientific information. Okay, a little bit about the National Bioethics Committee. This is a Gazette notified committee founded in 2004. And the REC, or the Research Ethics Committee, is one subcommittee of the NBC. And what do we look at? We look at any research that has been funded by international donors. We look at research which is funded by the government of Pakistan. Any research which is done all over Pakistan or is a multi-province, more than two or more provinces, it has to come to the REC. Or any drug trials, any clinical intervention, even if it's done at a single institution, that has to be brought to the REC. So how did we adapt to the rapid review process? Now, generally, the REC would have a turnaround time of about 6 to 8 weeks for reviewing. During the COVID pandemic, we converted that to 72 hours. And credit goes to our NBC Secretariat, because they were responsible for developing the SOPs for rapid turnaround review and notifying it and getting it approved by the Ministry of Health. And then it was posted also on our website. And email, now before COVID, we used to do email reviews. So 6 to 8 weeks, we used to just get emails from our reviewers, and then the chair or myself would collate those comments, and then we write back to the PI. But with COVID, we are we had Zoom meetings. We used to have Zoom meetings almost every day, especially in the initial period. And because although a lot of us are doctors, some of us are researchers, but we needed help from microbiologists, from pharmacologists, from intensivists, depending upon their expertise. So we co-opted a lot of people to review our projects. And we decided on that we will not in any way compromise on the quality of the review. As I said earlier, we are dealing with vulnerable populations. And so our review quality should not be compromised. So this is again available on our website, that you submit your project to the NBC REC, and the Secretariat will receive it. And within 24 hours, it will be sent to the chair and the other reviewers, and then we would meet and give our comments in this turnaround time. So why was this change successful on the REC level? On reflection, you can see there was good teamwork. The REC has like-minded individuals who are motivated, and yeah, I would say, we think alike. I would consider that as a strength, right, for now. Our secretariat was quite proactive. We had co-opted members beforehand. Now, we started receiving reviews towards the end of March. Remember, our first case of COVID came in end of February, but we were planning beforehand that we are going to get an onslaught of research proposals. So we had developed our RTR process. We had already invited co-opted members to help us with review, depending upon their expertise. And the lockdown, because it gave us time. So we were at home, we were not in our offices or busy with other work. So we were able to meet frequently on Zoom. And getting the times together was a challenge, but then we all compromised that evening time, 10 o'clock is the best time for us to meet on Zoom. And of course, a lot of us are in teaching institutions, so we're very familiar with using Zoom. So that's another plus point for the REC. So I'll be talking a bit about the challenges that the REC faced. And up till now, we've done about 90 plus COVID proposals. And one thing that we saw was that there was a lot of COVIDization, and I've put it in inverted commas. So because there was ample funding for COVID research, both nationally and internationally, any project, research project, you just add in a COVID element and it became a COVID project. And then we were bound to review it in 72 hours. So we never realized that this would happen. And so research, which was not that emergent, was given a rapid review process, was put into the rapid review process. And in retrospect, that led to a lot of burnout, including myself, because too many proposals, which I thought, I thought I was a bit out of my depth after 6 months or so. So one of the projects that we received earlier on, this was a time when COVID-19 we just reported our first few cases. Diagnostic kits, an institution and a respectable PI wanted to developed a protocol to make our own diagnostic kits. And it was announced prematurely in the media. I remember one minister coming up, I think on Twitter or something, he announced that, oh, we are in the process of developing our diagnostic kits. And so the political pressure to approve this protocol was immense. And, this was something that we required people from pathology and molecular biology to come in and help us to review the project. And we realized that, there was some compromise in the methodology. And the researchers did claim in their protocol that, this is once we develop this kit, we are going to be producing it on a mass scale. And that kind of raised alarm bells for us, because we understand our context, and we did not want to approve a project which had the potential of being, substandardized in a different part of the country. So, so the REC took a stand and we said, no, we can't, you have to relook at your methodology. And, we got a lot of influential people calling in and pressurizing the secretariat, pressurizing, please approve this project in the national interest and so on. But, but on the other hand, we were also thinking, if this project with its faulty methodology is approved, that would really reflect back on us, bad on us. And we can't allow that. So there was a stalemate between the REC and the research team, which eventually, we had to have a couple of Zoom meetings with the research team to try to convince them to relook at their methodology. And, so that kind of did but and so that kind of did work, but it was really challenging. This was one of the famous, and I think all panelists who are from Pakistan will be able to relate to this. This was the use of plasma therapy to treat severe COVID-19, and this was approved as a MURI. For those of you who are not familiar with this term, it's monitored emergency use of an unregistered intervention. And even before the REC received this proposal, a media hype was created. The PI came on national television and and I remember that all the big TV stations, they were highlighting this, that, you know, some revolutions are going to take place. So people were desperate for information. And because of that, there was a lot of therapeutic misconception among the population. There were obvious deviations in the protocol. The protocol mentioned treating severe COVID-19, but even on social media, on YouTube, on several channels, we could see that people with even mild disease were being treated with plasma. So, and so much so that plasma became a commodity and it began to be sold for innumerable amounts of money. REC raised our concerns repeatedly that please, you need to do something about the therapeutic misconception. The hype was unbelievable. And then we had to write back to the PI, and the PI did give us his preliminary results, which were not you know, that favorable, but we said, okay, fine, do an RCT. But you know, that didn't materialize for some reason. Another protocol that we received was using stem cells to treat severe hospitalized COVID cases. We asked about the harvesting facilities for stem cells within the country and whether or not they abided by international standards. And, you know, the PI wrote back to us that, you know, I've applied for the required certification, but you approve our protocol. And we said, no, we can't do that unless we are certain that, you know, because stem cells are a sensitive sort of topic for research and its usage and how it's going to be utilized and so on and so forth. So we withheld our approval till we were satisfied about their infrastructure for stem cell harvesting and culture. Then, interestingly, we had some trials for Chinese medicine. And this was a molecule that we were unfamiliar with. It did not fall under the DRAP. DRAP is the Drug Regulatory Authority of Pakistan, and their SOPs mention that they will be looking at pharmaceutical products for randomized controlled trials. And this was the first time we had a couple of Chinese medicines and a couple of herbal medicines being used. So we were not sure, you know, how to proceed with this. It was our first time, and there was no previous data available. So, you know, we allowed it on the grounds that, okay, you know, tell us the composition of the molecule, you know, give us some safety, tell us about, do a phase 1, phase 2 trial, and then we'll see if we can make it into a phase 3 trial. Okay, so this protocol really put us out of our depth. Ventilators were being manufactured for the first time in Pakistan, and the REC had no framework for review and approval of devices. We were not sure what to do with how to approve a protocol for devices. So the Secretariat of the REC, we met several times, and we looked at international guidelines to develop some sort of framework for approving devices. We had to co-opt relevant reviewers, and this included pulmonologists, some intensivists, some anesthetists, you know, and of course we needed some certification from the Pakistan Engineering Council, and they were really putting a lot of pressure on us. But you know, we said, okay, technical aspects, probably we're not the best people. So you know, we were able to work on these studies for a good 3-4 months. And then once we started getting in the proposals, it became easier for us to approve them. Another instance, a PI was involved in 2 competing vaccine trials in the same organization. So that was a bit of a challenge for us. We didn't know, can a PI be involved in 2 trials? We weren't sure about that, and we were trying to look up the literature to see if there could be how the PI can be objective in 2 trials. So I didn't think, but then again, if the scientific methodology was sound, and if we were satisfied with the way they were introducing the trial and how they were recruiting the people and how well they were looking at their side effect profile and so on, we did allow it. But again, it's still a question in my mind: can a PI be involved in 2 competing vaccine trials? Another issue interesting we thought was, as I said, we have limited infrastructure, and a PI was conducting a trial within a hospital which was owned by his own family. So we thought this was an obvious conflict of interest. The PI signed a declaration that there is no conflict of interest. So, we couldn't really do much about it. The latest that we have been receiving, the challenge was this placebo arm for vaccine trials. Now, last year when we had no vaccines, we were okay with this methodology because, it made sense. We didn't know whether the vaccine would work or not. But in March 2021, when the government vaccination program was rolled out, using the placebo arm became unethical. Because we could not tell our population, okay, don't get vaccinated, but enroll in this trial, because the vaccines had been approved under emergency use authorization. Well-known researchers from good institutions, including my own institution, they pushed for the trial because there was a lot of funding available for these vaccines, and there was an immense political pressure on us. And I remember getting emails and texts and messages that, REC is just being too hung up on the ethics, and you need to realize that we need the funding, and the funders, the funding agencies will only approve RCTs, which with the placebo arm. So that was a big challenge, and but the REC took a stand. We said no, we will not. How can we allow a placebo arm already where there is so much vaccine hesitancy? If anything, it will create more mistrust within the population. We were helped by the independent institutional IRBs. So 2 IRBs at least did independently review these projects, and they also did not approve it. So that gave strength to our claim that it was unethical. So that helped, and I'm grateful to those reviewers from these IRBs for presenting and taking a stand on this. Ultimately, what happened was that the researchers and the funding bodies were made to modify their protocols to make it ethical. And I think that is a big success for us. Okay, so some unique challenges. We were getting an emergence of researchers overnight. People who had no background in doing research were doing research. We had the DRAP, the Drug Regulatory Authority of Pakistan, whose purview is to approve clinical trial sites. And they were approving a lot of clinical trial sites. I'm not sure how well scrutinized these trial sites were, because when we raised the issue of a PI owning a hospital, which is a trial site, they didn't do much about it, unfortunately. As I said, we're not good researchers on the global map. So initially we had a lot of poorly written protocols, and we looked very carefully at their informed consent forms, and we were very particular that it should not give an impression of any therapeutic misconception. Unfortunately, we saw a lot of IRBs just being rubber stamps. So, a trial had been approved by an institutional IRB, and we were amazed at how this trial got approved with, gross, issues with it. So it made us question a lot of IRBs. And we realize that ethics oversight is highly compromised in our part of the world. So way forward, how we need to, as Farah mentioned, we need to have capacity building, not only for researchers. So the researchers should know how to do good scientific ethical research, but also reviewers should have a critical eye when reviewing such protocols and not fall under the hierarchy. And just because my teacher or my sir or whoever is, he may be a respected doctor in our society, but he may not be a good researcher. And I think we should have the moral courage to say that, you know, there is a problem with your methodology. Please look at it. I've written that we need to focus on conventional research and public health emergency research both, for capacity building. I would say you need to have a resilient team with moral courage. You know, when I mentioned that certain IRBs approved projects without, you know, proper information, without looking at the informed consent form, that made us question the capacity of the IRBs. We got good support from the Secretariat, but it could have been better. We felt that the Secretariat was, actually the good thing was the Secretariat took a lot of our pressure. So they would just transfer the pressure to us. You know, we need to strengthen our Secretariat as well. We need to have workshops on research ethics and especially on emergency health, public health emergency research. And someone very rightly said, any great change that needs to be taken, they are preceded by chaos. And no doubt the COVID pandemic was chaos for us, but there are important lessons for us to take away from this pandemic. Thank you. And I will end my presentation. Okay, I'm sorry, while I was presenting, I wasn't looking at the chat box. So, yeah, over to you, Farah.
Thank you, Dr. Saima. So that should not be a problem if you were not looking at the chat box. We plan to take the questions. So we do have many questions directed towards you, but I would take the liberty and use my privilege to ask my question first. So thank you so much for presenting the perspective of Pakistan so beautiful. And this, I was able to relate most of the things. I was already informed by a few matters that you discussed. I was familiar with the media campaigns and the pressures that we had faced at the institutional level as well. So thank you so much for mentioning all those in such an interesting way. So thank you so much for that. So while we'll take further questions, so my first question is, so I would like a response from Dr. Saima and maybe Elif or maybe Catherine, they can further add to it. So the perspective of the IRB, the context of the IRB, if you are in an ethics committee in a low-resourced country, where we do not have capacity to produce innovative research, or we have a limited capacity, and when we are trying to do some innovations, we might not, some of the researchers might not know how to do it well. So in an IRB or an ethics committee, which is in one of the developed countries, the countries who are leading the innovation, who do have the privilege to, and the research is initiated there, developed there, and they have some privilege to design the research that might be most appropriate for them, and they might have the privilege to engage with the community from an initial level. But when we are sitting in a country and sitting on an ethics committee, which is in a country which is primarily relying on research of others, and maybe looking at it as a hope for them, because at the start of the COVID-19, when we never knew when the treatment would be available, when the vaccines would be available. So it was not, I believe, it was not just external pressures. It was not just the pressures from the political leadership or the institutional heads. We had a pressure from inside, because from inside we wanted to facilitate the cure process. We wanted to secure something, secure some hope for our people. We can say it a national interest, or maybe a moral obligation. So, so how would you like to respond to that? So, because I have seen that the way you have presented, that you were able, and I would congratulate you and the National Bioethics Committee and all the members, that the way you were able to take a stand, and the way you have handled the pressures, and I know how it has been. So, but what about the pressure that one may feel from inside? So I would like to hear from you.
So all right. So let me for clarity's sake say that you mentioned privilege of international researchers with the money to come into Pakistan and say, okay, we're going to fund this research on your community. Then we responded by saying, then it is our privilege as representatives of Pakistan not to make our communities, not for our communities to be exploited. So that is our right and our privilege. And if we do not speak up for our communities, then who will? You are definitely right that a lot of pressures came from within, from very high-ranking researchers and bodies. And we were blamed for being, a hindrance to research. And they said you don't want research to happen, and they were questioning our credibility. And but we said, fine. I mean, you satisfy us on these ethical grounds. And I said, and I remember one particular PI constantly telephoning and telling us that the NBC is a hindrance, and they do not want research to happen, and they're just sitting on their ethical high horses, and so on and so forth. And there is a lot of, remember, we are a very emotional people, and we have national causes. They're very nationalistic. That may be fine for cricket matches, but it is not fine when you're doing good quality research. So I would just respond by that. And we had, the sad part was, I mean, forget about the vulnerable communities that we're doing research on. The sad part is these are educated people who are from good backgrounds, they're privileged, they're influential, and they are saying these things. So I would think that, yeah, I'm not paid for what I do, neither are the REC reviewers. So we are no way obligated to pander to people's requests. So I think that's, we're independent. So that helps. So I hope I was able to, David said integrity. Yes, if anything, RECs, IRBs should have and show integrity, and as much as the researchers.
Thank you so much for this beautiful answer. So we do have many more questions. So I would try to take a few of those. I would try to group similar questions together. So Asim Khanum from Lahore, Pakistan is asking, in LMICs who do not produce vaccines themselves, vaccine trials are a way to get vaccine for their population, maybe the only way to get vaccine, or maybe our only way to get access. The manufacturers might take advantage of that. How is the ethical review process undertaken for such trials, and what point should be considered before giving approvals? I can see that you have already partly answered this question. So I would like to read out another question, and you can respond to both of these. So Shahir Banu is asking, so for future prospect, is the NBC REC working on any mechanism to minimize this unexpected influences during health emergencies? So how would you like to respond to this?
Okay, so REC can only do so much. Remember, we are answerable to the, I think, the Ministry of Health. So we can create a lot of noise. We can, yeah. We'll make noise if we feel that. But whether we have any teeth to do anything, no, unfortunately, we don't. But I think this is a wake-up call. I hope that through this platform, researchers should develop some scientific integrity, and let's be prepared for research. Let's be prepared beforehand. If another pandemic comes, we need to get our information. One thing I found was that researchers and institutions, they have some egos. If you point out a flaw in their methodology, they get really upset. So, I think let's learn some humility as well, because if anything, COVID pandemic has taught us humility, the humility of being ignorant of a lot of things. So.
Thank you so much. So you talked about vulnerability. So the vulnerability and how the vulnerabilities have evolved, and the new concept of vulnerability. At some point in time, we felt, are all of us vulnerable? And then we have witnessed that few countries were more vulnerable. Those who were vulnerable to start with, their vulnerabilities just worsened. So what is the difference? If again, how the vulnerabilities would be affected by the context in which the communities are there, as well as for ethics committees, as well as for the national level leadership, both political leadership and scientific leaderships. So at all these levels, the vulnerabilities, how these differ for a low-resourced country like us versus a country which is more developed. So I would like to have a comment from Dr. Saina first, and if any of the panelists would like to respond to this, so it would be great to hear from others. Dr. Saina, please.
Okay, so as I mentioned in my presentation, it just occurred to me when I was listening to Catherine that vulnerability can even have levels, because we are living in a hierarchical society. When we talked about community engagements, even communities, there are multiple communities within Pakistan. So I would think we need more research on this, because I'm not an expert on community engagement. I know Dr. Mariam made a comment about community engagement, but we're talking about it so much. You need to understand what your communities are. Who are your communities? And from my experience, what I've seen is that when we talked about vaccine trials being conducted in Shifa, where I'm from, or when we talked about certain trials that Shifa was involved. And I remember Shifa is catering to a community of relatively privileged people from Islamabad. So, and they're more educated, they're from a privileged background. So that could be a different community. Vaccine trials in Shifa who was the community? The community were first of all, the community was the staff who volunteered for those vaccine trials. And their engagement was important, and it was probably easier because they were within the healthcare system. The community or the participants for the vaccine trial were our medical students, who are again from privileged and educated backgrounds. So engaging with them would be much easier. But then when you're taking it to a community in one of the far-flung areas of Islamabad or Pindi or whatever, then your community, you need to understand your communities. I think, let's relook at our communities and our engagement levels. When you were mentioning, Farah, that what is a measure? So measure would be getting more knowledge about your communities and understanding their backgrounds. And that once you are available, and probably you'll need to take people like anthropologists to understand communities and how they function and how they behave. So this is something that could be some new ideas for research in the future.
Thank you so much, Dr. Salman. So here I would like to see if any of the panelists would like to respond to this question in addition to Dr. Salman. So how the context is material. So Ms. Catherine Wright, it would be great to hear from you.
Thank you. And just a really big thank you for Dr. Simon for your help.
Thank you.
on what you've been doing for the last 18 months. I just found it quite overwhelming. All the almost theoretical or historical issues we looked at, you faced in real time and had to give answers to. And I just found it really admirable and inspiring. So thank you. I think this question of vulnerability is absolutely fascinating. And I think you're really right to sort of link it with the sense of we don't just have one community or even one physical community. We have many multi-layered and complex communities. And I think the challenge is that I think traditionally in research ethics, we've thought of as certain groups as being vulnerable. And the classic idea was they're a vulnerable group and therefore they shouldn't be in this study because it's sort of safer not to. And by the time you've added them up, it's basically everyone who isn't a young man, isn't it? You exclude children, you exclude older people, you exclude disabled people, you exclude pregnant women, you exclude prisoners. I mean, interestingly, when you're talking about doing studies with medical students, in some contexts, that might be considered a hierarchical challenge if people didn't feel free or not to take part. So employees have also been regarded. I think one of the arguments we've made in our projects over the years is we need to think in a more nuanced way about vulnerability and recognize that we can all be vulnerable, you know, even outside an emergency, but even more in an emergency. But also that we can be made more vulnerable by being excluded from research. And I find it particularly striking, I think, under the vaccine trials, I think two particular angles. One, you know, I think in a lot of the pharmaceutical trials, they tried or left open, including older people, but actually their systems didn't actually encourage that. So then, you know, the numbers and the effectiveness of the vaccines in older people, you know, they weren't there for statistical validity, and yet that was the group that should be targeted most first. I mean, leaving aside all the questions about what's happened since in terms of access. And then the second issue I think has been really interesting is that pregnant women were just routinely excluded as they usually are. And then that's been a real issue around vaccine hesitancy, because I think a lot of the reasons why people in the UK and elsewhere are younger women are being hesitant about having the vaccine is because of this perception of it's not safe in pregnancy. So, you know, what appears to be a sort of safety first measure in terms of, well, we routinely don't involve pregnant women because we don't know about the impact on the growing child. You know, it then transfers into a complete lack of healthcare for pregnant women meeting their needs, and in this particular case, in terms of real lack of confidence in the vaccine as well. So, you know, I think we have this challenge we mustn't forget about vulnerability. I think that would be a massive mistake, but we need to think in a more nuanced way and say, well, who in this study, in this context, might be particularly vulnerable? You know, we all have a degree of vulnerability, but who might be particularly vulnerable? And then secondly, rather than saying, well, let's just not include them in our study then, thinking, are there things we can do within our study design to actually mitigate that vulnerability or even remove that additional vulnerability altogether? So it's you know, vulnerability remains a really important concept, I think, but we have to move away from using it as a group concept that is fixed and just means you're not part of our study, and think about it more in a more nuanced way. And I think you've described lots of ways in which that's been done. Thank you.
Thank you so much, Ms. Catherine. So here, what I would like to do is I would join a few questions which are directed towards the National Bioethics Committee of Pakistan. I'll try to join all of these questions for a response from Dr. Salma, and then we can move towards a focused session where I would like that all of us should be able to ask questions and try to find answers to difficult questions. And I would like to come back to the concept of exclusion in clinical trials. So I would like to take this up in the later part of the discussion. So few questions which are directed towards the National Bioethics Committee of Pakistan, and I would request Dr. Simon to respond to these. So my colleague Ikra is providing me a great support from behind the scenes. You cannot see her, but she's the one who is keeping me informed with most of our communication. So I have a question from Ikra. So let me read this out for Dr. Simon. So delays have been observed in ethical approvals of pandemic research. On research could be lack of communication between IRBs and also between IRBs and NBC. Can harmonization in ethics review among different reviewing bodies can help? And she has further asked this harmonization or maybe a coordinated review, in her opinion, is one way to overcoming the delays. So I would like to build on this, like having a harmonized review system might be easy for the researchers as well. So that is one area for discussion. And as well as one of my colleagues, Dr. Mariam, has also asked that it would be great to know if NBC Pakistan, they have used specific criteria for review of research, which has a focus on COVID. So I hope I can have an answer from Dr. Simon.
Okay, so with relevance to your first part, which is talking about local IRBs and harmonization with the NBC, let me state that the NBC, REC, I can't say for the NBC, we're just a subcommittee. So the REC is open to communicating with IRBs. So, you know, if an IRB has a certain query regarding a project, we are open. You just drop in an email, we can have a Zoom meeting. So, you know, let me make so that, you know, let's learn from one another. And because a lot of the things that we're getting is through emails and, you know, soft copies of projects. So back and forth. So yeah, there's no problem so long as you reach out. And because what we do is we just write back to the PI. So it's a good idea. Let me tell you that, you know, again, as an NBC reviewer, I would say, sorry, as an REC reviewer of the NBC, I would say that, you know, institutions over time develop a credibility. So, you know, if a certain institution in Pakistan responds back to the PI with good quality, responds to the REC with good quality protocols and very well documentation and so on. So then, you know, as a reviewer, I'm more confident in approving those. So credibility of the institution carries certain, I would say, a bias. That does not mean we do not review those processes without critically examining them. But then my request to all researchers is that if you are sending a project, or institutional heads, if you are sending a project to the REC, please keep in mind you are representing your institution. And if we see a lot of flaws, lack of ethical oversight, that will, if anything, make us question your credibility. And we don't want that. We want institutions to develop good research. We are all pro-research, even though whatever anyone else might say. So I think that is one way. Reach out to us and we will respond. Even you know, if we can meet on Zoom, that's also possible. So with the entire IRB. So that's not an issue. You're talking about Mariam's question, specific criteria for reviewing. No. I mean, I think if anything, the REC, the good thing was that we, as I said, we're like-minded people and most of us have a background in bioethics. So, and even the co-opted reviewers that we took on were people who were well-versed in this. So again, we had the WHO guidelines available and we did refer to those, but we just refer to those and use our collective wisdom. So I think, you know, the fact that the REC has people who are cognizant of ethical issues in pandemic research, that helped. And the fact that, you know, if we didn't know anything, we'd always ask people who would help us out. So I think another thing to learn is that we're all in the learning process. So yeah, I hope that answers both of your questions.
Thank you so much. And yes, this is the approach that we have learned, that learn, evolve, and learn and evolve. Thank you so much for mentioning that. So it's like a question, and I would like to ask the panel. So there could be ethics committees. So there could be a situation where a certain research proposal is approved by certain ethics committee, and at the same time it is disapproved by another committees. So the researchers might have the liberty to shop around, and because they would have approvals from the committees, which are maybe lenient or maybe who haven't picked up significant issues. And at the same time, there are other committees who might have raised or identified significant flaws or ethical concerns. So I find it a very difficult situation and not sure how to deal with this. So any guidance would be helpful. Thank you.
Okay, so in that, I would say, well, we haven't faced that much. I think what we did face was a local IRB approving a protocol, and then the NBC said, no, but this is not ethical. How can you approve it? And so what happened was that, the PI said, my IRB has approved it. And we said, well, no, we question your IRB and how it's functioning. So then we haven't approved it. And so we said, you have to change this methodology, inform your IRB, tell them that this is what the REC is saying. So, the buck will stop at the REC. And whether or not it's a good thing, or because, we've also had some experience of how the DRAP functions. So the DRAP will not approve anything without the NBC REC approval, which is a good thing, because that gives us a lot of leverage. But then on the offhand, on the side, we get a lot of pressure from the people from DRAP that you need to approve that, and the scientists and the this and that and so on and so forth. But again, it's the resilience to stand to those pressures. Credit to our secretariat, because they take those pressures and then they direct them to us, and we usually give our recommendations in writing. So people find it and we try to be as logical and as so it would be difficult to refute. So if a project is being approved by one and not approved by the other, I would probably be more I would give credence to the IRB that is not approving it rather than the one that is.
So maybe this leads us to think about this, that maybe while the different ethics committees or different bodies, ethics committee as well as the national bioethics committees, they are approving a similar project. If it is possible to have a sort of coordinated review or maybe a proactive communication between us, so
Definitely,
we are not blinded. Yes. So
yes,
thank you so
why
much.
not?
Yes. So this would be a great support in that case, because at times at the institutional level, it is hard for the ethics committees to take a stand, because the ethics committee, their secretariat, their members, they are on the payroll of the institution. So this is so hard. So if we could have a more sort of synergies, and that is something that the ethics committees would feel empowered, and that's like sharing the capacity. So thank you so much, Dr. Simon. So we are moving towards like our last part of the discussion. So I do not like to we can't just say that one session has ended and the last session has started. But yes, we will be taking more questions, and we would be we look forward towards hearing from our panel members in our last part of the discussion. So we started off with when Ms. Catherine Wright, she has presented the work of Meaningful Concept in Bioethics, and that's an in-depth inquiry, and they have presented their work and their findings and their recommendations, as well as their call for action to duty bearers. So I had a chance to ask her about the relevance of, so what I would like to start my discussion with is like, what is the relevance of the previous work and the findings to the current ongoing pandemic? Are there any new learnings? And the one topic that is like would interest me, and that is my personal curiosity to learn, after having this perspective from Ms. Catherine Wright, and as well as we have heard from Dr. Simon. So, and I've taken a note that Ms. Catherine Wright is open to the idea that how we can build the work further in different contexts, right? So here I would like to open the discussion to have an opportunity to learn that what we have learned from previous emergencies and how to take in account the context and maybe starting off with the learnings of Newfield Council on Bioethics, how we can build on that. And do you, and my question is, my first part of the question is directed towards Ms. Catherine Wright. After having today's session, do you feel that there is a need to have a dedicated section or maybe extending the current recommendations for a country which is low resource and which has been facing diverse challenges, which Dr. Sanma has just elaborated so beautifully. So if I can have a comment of this.
Thank you, Dr. Farah. I mean, I think, as I said earlier, it's been an extraordinary 18 months, having worked for sort of 2 or 3 years, looking at, I think, particularly at Ebola, but also Zika, SARS, and then many other kinds of emergencies as well, because we looked at experiences in natural disasters and so on. I think so much of what we heard really playing its way out in the world over these 18 months. I mean, just picking up Dr. Curry's comments earlier, which I didn't respond to, this idea about the fog of research, the fact that there may be lots of very good studies, but they're all competing and some are more important than others. I mean, that was a really big issue during Ebola, and that we highlighted, and this need and yet difficulty in what systems are in place to prioritize those. Because it's very hard for individual ethics committees to say, well, we'll have this, but not that, because you tend to look at what comes in what order. So whether you need that national level to do some kind of control. I think the learning for me, which I think has been very salutary, and I think for the UK, for Europe, for America, is this this realization that actually everyone is vulnerable to emergency. I think in the past it's been too easy for the source of a lot of the funding and some of the research, though I think that central gravity is shifting very rightly to other countries. But a lot of the funding has always come from areas where it's been going out there to do research and then coming back to your safety at home. And I think if it's the right word, it's been very good, I think, for people in the West, to actually face the reality of it. I think the outcome in terms of vaccine access has been very unsavory, but I think that's another question that we've touched on. And in terms of learnings for the future, I mean, as I said in the note and in the chat and personally, I mean, I'm just so impressed by what Dr. Sama described of how the NBC REC responded to these kind of questions, including, I think particularly the ability to push back against political pressure, against the pre-announcing of studies that were then going to come to the ethics committee. And interestingly, I mean, I heard that happen in the UK. I know it's happened in Chile. I know it's happened in Guinea. It's obviously a common threshold and the common experience in many different countries with different kinds of governmental experience. I think, though, one of the other, oddly enough, I think one of the sort of strong messages for me in the work that we did was that a lot of these ethical challenges aren't new or specific to emergencies. It's more that emergencies bring them to us at a particularly acute and difficult way. And a lot of the questions around vulnerability, around flexibility of ethics review committees, around how we should respond to the sort of human nature of how people are feeling and not just be very, very intellectual about it. We have to respond to emotion as well. I think the importance of countries being involved in prioritizing their own research and not being a dumping ground for other people's research. All these kind of questions, they're so true outside the emergency context too. So I think there's so much we can learn and build on in that. But I do feel very strongly that it has to be for individual countries and then also countries' regions as well, for example, within the WHO regions, to explore what is most at stake for them, because so many things are context dependent. And while I think I find it quite exciting developing the ethical compass, because it really felt like we had found identified shared values, unlike, for example, a very Western focus on autonomy, which I think is something that's very challenging in many parts of the world. And we don't really behave like that ourselves, actually, in the UK and the US. We do think collectively within our families and so on. But I think the ideas of very Western ideas of autonomy have become so dominant, it's quite hard to challenge. I think ideas of what it is to be fair, what it is to be respectful, what it is to reach out to other people suffering, and what's the most appropriate way of responding to that, that did feel like something genuinely global from, you know, from the input we were able to have across the globe. And of course, that still excluded many countries. And I hope that is a useful tool for others to move forward with. But I would be the first to say, you know, this is not just a given answer that other people should just take. I just hope it's a useful contribution. Ironically, our original plan when we launched the report was to have a series of meetings around the WHO global regions, in each of the regions, and being able to work with partners that with partnerships we've made during the project, you know, to have those kind of discussions. And that didn't happen because of COVID, apart from one very early meeting. But this kind of opportunity, I hope, is another way of doing that. And, you know, to the extent that what I presented speaks to your experience in Pakistan, you know, I really hope that's of value. But I would make no claims that it's the end of the discussion. Thank you.
So much. So essentially, when I have read the recommendations and the call of action made by the in-depth inquiry of the neutral council of bioethics, I could just agree to all the recommendations. So wonderful work, I must say. So we have already discussed, this is not a new question. We have discussed in this session, we have discussed already at different forums. And as we have just said that if one of us would fail, everybody would fail. But and we have noted that it was hard to come together when it came. It was about the response. It was about the initial response. It was about the vaccine distribution and many similar challenges. So, so I would like to ask that how we can build respectable collaborations between developed world and underdeveloped world. This is not a new question as I asked, but maybe I would need to ask it from the perspective that who is duty bearer here to ensure a fair collaboration where both the two parts of the world, they have fair terms of collaboration. If possible, I would like to have a response from Dr. Elif, if she could respond to this, or the floor is open for other panelists as well. Just let me know who would like to go first. Thank you.
Yeah, thank you, Farah. I think the responsibility is on all parties. Not only the colleagues from more developed countries, or not only on the colleagues from low and middle income countries, but all people. And when we are collaborating, we should just ask ourselves, why are we collaborating? I mean, what's the aim of this collaboration? Is it because we don't have any other ways to rescue ourselves from this chaotic situation? So is it because of some kind of an expectation of a benefit only, or is it because this is a risk and crisis for all humanity, and that we should build some kind of a solidarity and some kind of basic values, and recognize those basic values and respect each other and try to, you know, help all the humanity? I think this is a very fundamental question, because if we can answer this question, then we can define the structure of the collaboration as well. And this would be a win-win situation for all parties, instead of, you know, some dominance of some parties and sacrificing others. And to my understanding, this pandemic showed us that we are not at that point now. I mean, collaboration is maybe on the expectation of some kind of a benefit, but it's not based on essential values that I have been talking about. And this is a risk for sustainability of collaboration, and also for for future public health emergencies. It's a risk for future public health emergencies as well, because when I was after my presentation, I was talking about transparency and losing trust and confidence. And when this is lost, then in some countries towards other countries, then any other kind of collaboration in the future, even in the preparedness phase, not in the crisis phase, but in the preparedness phase, people would feel some kind of a distrust, and people may find it really hard to share their experiences and what they have gone through with others sincerely, because of the bad experience. So I personally believe that we have to learn to collaborate, but maybe we should rethink about the basics of the ethical values that we should all consider and rely on when we are building any kind of collaboration between agencies, between countries, within an international institution. I mean, any kind of collaboration I'm talking about.
Thank you so much. Thank you so much, Dr. Elif. So here I would like to make a small note that we do have few questions which I think have been unanswered, but quickly having a look at that, I believe that this has been covered in one question or the other. But I would promise you that we will like to respond back to any questions which would be left unanswered, maybe after this session. So because going forward, we are having few questions for the panel, as well as we do have, we would like to have we would like to hear from Dr. Mariam. She has to say something about another session that is being planned as part of the symposium. So, so just a small note that we have noted all the questions, and I would be trying to answer all of those within the session, and if anything is left, we will try to come back to these questions later. So Dr. Elif has pointed out about trust. So so this has been reported that COVID-19 misinformation has had a direct negative impact on health of communities. At times, public was using dangerous cures, remedies, which had no scientific evidence of benefit. At times, these were even dangerous. They were damage to trust in health, in institution, in scientific leadership, in political leadership. It has led to vaccine hesitancy. So, we are all aware of this. So we need to ensure that communities know what to trust, and more importantly, what not to trust. This is so important. So I would like to ask, has scientific community has identified this challenge and put an appropriate set of efforts to address the misinformation? Or in the later part of the question, I would like to ask, is this really a job or duty of the scientific community or the political community, or maybe all of us? So I would like to hear from my panel. Just let me know who would like to respond to this.
So if I may talk about, Farah, about you're mentioning the scientific community versus media pressures and dealing with, okay, so I don't know. Honestly, I don't know, because this is the first time that, I've been involved in reviewing pandemic research. This is the first time I've experienced such issues. And I have been approached, several times for coming on the media. I'm very media shy. I make it a point not to be involved, and because I don't want to be quoted out of context. So I make it a point to attend, forums and academic forums and discussions. I don't know, because our media and the regulation of our media is quite questionable. So I think in our part of the world, because, and then not only the media, or the screen media, but also social media. There's a lot of misinformation going out there. So maybe Catherine or Elif can talk about their perspectives. Were you able to control that? I know in our part, it's not easy.
I can see that Dr. Elif would like to respond to this.
Yes,
so please go ahead.
Thank you. So I don't know the answer to this question, but I can only share my observation of what happened in Turkey. I think the scientists, the academicians cannot escape from this, from the pressure from especially social media. I mean, some professors in Turkey have been the face of arguing for